Welcome to the Deep Dive, where we slice through the noise and get straight to the crucial knowledge you need to be well-informed. Today, we're taking a really close look at a challenging medical problem, refractory osteomyelitis, and the specific, sometimes debated role of hyperbaric oxygen therapy in treating it.
It really is. It's a condition that forces clinicians to look beyond standard approaches when those fail. Understanding why and how adjunctive therapies might fit in is absolutely key.
Absolutely. And our source material for this deep dive is drawn from an in-depth publication focused precisely on this topic. It lays out the complexities, the proposed mechanisms, the evidence, and, the practical considerations.
Yeah, it's quite comprehensive.
Our mission today is to go through this material, really unpack it, and understand exactly what refractory osteomyelitis means, why hyperbaric oxygen therapy is even on the table as an adjunct, how the science suggests it works at a fundamental level, the clinical specifics of how it's utilized, what the accumulated evidence actually tells us about its effectiveness, and then weigh the practical aspects like who's the right patient, safety, how we assess its continued use, and the impact on cost.
We're essentially building a comprehensive picture from the ground up based on this source, a roadmap, if you will.
Exactly. So our journey through the source material will start with defining refractory osteomyelitis. What does it mean when a bone infection just won't quit? Then we'll delve into the proposed mechanisms by which hyperbaric oxygen therapy might help the biological why.
Right, the science behind it.
Next, we'll tackle patient selection, who are the best candidates, guided by systems like the Synergistic classification. We'll examine specific anatomic sites where this condition is particularly difficult and where this therapy might be uniquely beneficial.
Those special indications.
From there, we'll get into the details of clinical management, the pressures, the durations, the frequency of treatments. Crucially, we'll scrutinize the evidence supporting its use, drawing from both animal and human studies, and see how that translates into American Heart Association class recommendations.
Which are really important benchmarks.
Definitely. We'll touch on safety aspects and how utilization is reviewed. And finally, we'll explore the often asked question about the financial implications. Does this therapy add cost or potentially save money in the long run?
A lot to cover, but it's all essential for a complete understanding, really.
Let's start then by defining this challenging problem, refractory osteomyelitis.
Okay, right from the top, the source highlights that the Centers for Medicare and Medicaid Services, in their National Coverage Determination 20.29, explicitly identifies chronic refractory osteomyelitis as a condition for which adjunctive hyperbaric oxygen therapy is covered.
Oh, interesting. So it's already got some official recognition.
Exactly. This immediately tells us it's not some fringe or purely experimental treatment from a regulatory perspective. It's recognized for a specific purpose.
That recognition is significant. But what exactly does the term refractory mean in the context of a bone infection? The NCD 20.29 offers a definition.
Yes. It defines it as being unresponsive to conventional medical and surgical management. Now, to translate that into practical clinical terms, the source explains that a patient is appropriately diagnosed with chronic refractory osteomyelitis when they show no significant improvement or even worsening of their bone infection, despite having undergone a full 30 days of combined conventional surgical and medical treatment.
Okay, so 30 days of the standard stuff isn't working.
Right. And that combined approach specifically must have included systemic antimicrobial therapy antibiotics that are circulating throughout the body. So the key threshold here is a failure to respond to the standard multimodal approach, appropriate surgery, plus appropriate systemic antibiotics over a sustained period of at least 30 days.
So it's not just that the antibiotics didn't clear it on their own or that surgery wasn't enough. It's when the 1-2 punch of surgery and antibiotics, given properly for at least a month, hasn't worked. That time frame and the combination are crucial to the definition.
Precisely. It implies that the easily treatable component of the infection has persisted despite best efforts with conventional therapy. Now, when we look at the evidence supporting the use of hyperbaric oxygen therapy in this specific context, the source is very clear upfront. To date, there are no conclusive randomized clinical trials specifically designed to examine the effects of hyperbaric oxygen therapy on refractory osteomyelitis.
Okay, the gold standard of evidence isn't available yet for this specific indication. That's a common theme in some areas.
And especially with complex interventions. The source discusses how many of the early studies that showed positive outcomes were conducted in hospital settings. The thinking is that the controlled environment of a hospital might have helped ensure better compliance with the entire treatment regimen in not just the hyperbaric sessions, but also the complex post-surgical care and antibiotic schedules. And indeed, the outcomes from these more controlled inpatient studies haven't always translated exactly when the therapy has been applied in the outpatient clinic setting.
Right, compliance is always tougher outside the hospital.
Yeah, the source suggests this could be due to differences in patient compliance or perhaps other factors that are just harder to control outside of a hospital.
That makes sense. It's harder to maintain a perfect treatment protocol in the real world. But despite the lack of those definitive randomized trials, what's the overall picture that emerges from the comprehensive review presented in the source material?
Well, the overall conclusion, based on the breadth of the scientific literature reviewed, is that the addition of adjunctive hyperbaric oxygen therapy to routine surgical and antibiotic treatment for previously refractory osteomyelitis appears to be both safe and, importantly, ultimately improves infection resolution rates.
Okay, safe and seems to help.
So, while not proven by large randomized trials, the accumulated data across many studies points towards a positive impact when used as an adjunct.
Safe, and it seems to help resolve the infection. Good news there. And under what conditions does the source suggest we get the best clinical results?
The source emphasizes that the best clinical results are typically obtained when hyperbaric oxygen therapy is administered concomitantly with culture-directed antibiotics, meaning the antibiotics are specifically chosen based on testing the bacteria from the infection and initiated soon after clinically indicated surgical debridement.
So timing is key, hitting it right after the cleanup.
Exactly. This reinforces the idea that hyperbaric oxygen is not a standalone cure. It works best as part of a comprehensive multimodal approach, essentially. A powerful triad of effective surgery, targeted antibiotics, and concurrent hyperbaric oxygen therapy.
The triad surgery, antibiotics, and HBO2 working hand in hand. Got it. But the source also mentions specific situations where extensive surgery or removing fixation hardware is considered relatively contraindicated or just too risky. What sites are those, and how does that change the approach?
Yes, there are critical anatomic sites where aggressive, extensive surgery might be associated with high morbidity or mortality, making clinicians hesitant to proceed with it up front. The source lists these: cranial osteomyelitis, infections of the skull; spinal osteomyelitis; sternal osteomyelitis, infections of the breastbone, often after cardiac surgery; or osteomyelitis in pediatric patients.
So really delicate areas or vulnerable patients.
Right. Because of the delicate nature of these areas or the vulnerability of the patient population, undertaking radical surgical interventions might not be the first or best step after standard antibiotics fail. In these specific scenarios, the source states that a trial of systemic culture-directed antibiotics and hyperbaric oxygen therapy prior to undertaking more than limited surgical interventions provides a reasonable prospect for osteomyelitis cure.
Ah, okay. So a chance to avoid the big risky surgery first.
This is a key clinical pearl. In these higher-risk delicate sites, hyperbaric oxygen can be part of an attempt to clear the infection without resorting to highly invasive procedures right away, offering a potential alternative pathway.
So it can offer a less morbid option in those crucial areas. Now let's get into the specifics of the therapy itself. How is hyperbaric oxygen therapy typically delivered for this condition?
The ordinary delivery parameters, as described in the source, involve sessions given on a once-daily basis, usually 5 to 7 days per week. Each treatment session typically lasts for 90 to 120 minutes.
Okay, daily. Hour and a half to 2 hours.
And the pressure used is between 2.0 and 3.0 atmospheres absolute pressure. We often refer to atmospheres absolute as ATA. It's the unit of pressure in hyperbaric medicine, representing the total pressure relative to a vacuum. Breathing 100% oxygen at 2 ATA is equivalent to the pressure felt breathing air about 33 feet underwater.
So one session a day, about an hour and a half to 2 hours long, at pressures roughly equivalent to being 33 to 66 feet below the surface. And how long does this initial course usually last if the patient is responding well?
If prompt clinical improvement is observed, meaning the infection is showing signs of getting better with the combined indicated surgery, appropriate antibiotics, and the concurrent hyperbaric oxygen, the existing regimen of antibiotics and hyperbaric oxygen therapy should be continued for approximately 4 to 6 weeks.
4 to 6 weeks seems standard for a lot of osteo treatments.
It does. This time frame is often linked to the period needed for surgically debrided bone to reestablish healthy blood flow or revascularize.
And approximately how many sessions does that translate to within that time frame?
Typically, 20 to 40 hyperbaric oxygen sessions are considered sufficient to achieve a sustained therapeutic benefit over that 4 to 6 week period, depending on how many days per week the treatment is given.
20 to 40 sessions.
However, the source acknowledges that there may be occasional, more complex situations where up to 60 hyperbaric oxygen sessions, coupled with 8 weeks of antibiotics, might be required to reach the desired therapeutic benefit. It allows for individual variability in the patient's response and the complexity of the infection.
Okay, that's the plan, if things are progressing positively. But what happens if that prompt clinical response isn't noted? Or perhaps the osteomyelitis seemed to get better, but then recurs after this initial treatment period?
This is a critical point for clinical decision-making and utilization review. The source explicitly states that if prompt clinical response is not noted, or if osteomyelitis recurs after this initial treatment period, the typical 4 to 6 weeks or 20-40 sessions, then simply continuing the current antibiotic and hyperbaric oxygen treatment regimen is unlikely to be effective.
Right, don't just keep pushing forward with a failing plan.
Exactly. This is a key message. Don't keep doing the same thing if it's not working.
What should happen instead?
Instead, the clinical management strategies must be reassessed. This involves a careful review of the patient's overall condition and, crucially, considering additional surgical debridement and older modification of the antibiotic therapy.
Back to the other parts of the triad.
Right. The focus shifts back to optimizing the foundation of the triad, the surgery, and the antibiotics. Only subsequent to these necessary modifications, performing additional surgery if needed, or adjusting the antibiotic choice or duration, should reinstitution of hyperbaric oxygen therapy be considered. The source states that accumulated clinical evidence suggests that bringing hyperbaric oxygen back into the picture after optimizing the surgical and antibiotic components will again help maximize the overall chances for treatment success in these persistently refractory patients.
That makes perfect sense. Hyperbaric oxygen is an adjunct. It supports the primary treatments. If the primary treatments, surgery, antibiotics, aren't fully optimized or need revisiting, adding HbO2 on top of a failing foundation isn't going to fix it. You fix the foundation first, then bring the adjunct back in to boost the new effort.
Exactly. It emphasizes the importance of the comprehensive approach. It's not a magic bullet on its own.
Let's take a quick micro recap of this introductory section, setting the stage for our deep dive.
Okay, so refractory osteomyelitis is defined by CMS and clinically as a bone infection that fails to respond to at least 30 days of combined standard surgical and systemic antibiotic therapy.
Got it. Failure after 30 days combined standard care.
Right. And while randomized controlled trials are lacking, the overall literature suggests adjunctive hyperbaric oxygen therapy is safe and improves resolution rates, working best as part of a triad with culture-directed antibiotics and surgery.
Safe, improves outcomes, best with the triad.
For delicate sites like the cranium, spine, sternum, or in children, a trial of HbO2 and antibiotics may be considered before expensive surgery. Treatment is typically once daily, 90-120 minutes, 2.0, 3.0 ATA.
Standard parameters.
For 4 to 6 weeks or 20-40 sessions if successful. But if improvement isn't prompt or the infection recurs, continuing the same regimen is ineffective. The management strategies, particularly surgery and antibiotics, must be reassessed and modified before potentially reinstituting HbO2.
Reassess, modify, then maybe retry HbO2. Okay, that gives us the definition, the context, and the basic plan. Now let's dive into the biological why. What is the mechanistic rationale that makes hyperbaric oxygen therapy a logical consideration for bone infections?
Well, the source traces the initial reports suggesting a beneficial therapeutic effect of hyperbaric oxygen back to the 1960s, but it's the subsequent studies conducted in the lab and in animals that have really worked to uncover several specific mechanisms by which hyperbaric oxygen contributes to treating bone infections.
And is there one core idea that connects all these mechanisms? Is there a common theme?
Yes, there is. The common thread across essentially all of these proposed mechanisms is the restoration of normal to elevated oxygen tensions in the infected bone tissue. Think of an infected bone as being in a state of hypoxia, critically low oxygen levels.
A hypoxic milieu, as the source calls it. Sounds pretty bad for healing.
It is. And key research, notably by Mader and Yanikoski, demonstrated that the decreased oxygen tensions typically found in bony infections can be returned to normal or even above normal levels just by having the patient breathe 100% oxygen inside a hyperbaric chamber.
So step one is just getting more oxygen in there.
Right. And Achieving these elevated oxygen tensions has crucial consequences for that low oxygen environment characteristic of osteomyelitic tissues.
Okay, so step one is getting more oxygen into the infected bone. Why is oxygen so critical for fighting infection?
It's critical for several interconnected reasons, starting with our own immune system. The white blood cells that are crucial for fighting bacterial infections, like neutrophils and macrophages, require tissue oxygen tension levels of at least 30 to 40 millimeters of mercury to effectively destroy bacteria.
Okay, they need that minimum level to work properly.
Yeah. How do they do this? Through powerful oxidative killing mechanisms. Imagine a neutrophil trying to power its internal machinery to generate the chemicals needed to kill bacteria. That machinery needs a sufficient oxygen supply to run effectively.
Like an engine needing fuel.
Exactly. The source explains that this leukocyte-mediated killing of aerobic bacteria, including challenging organisms like Staphylococcus aureus, is significantly enhanced or restored when the low oxygen tensions intrinsic to osteomyelitic bone are increased to physiological or even supraphysiological levels.
So it's not just that the immune cells show up. They need the right environment, specifically enough oxygen, to activate their most potent killing methods.
Yeah. Precisely. And Mader and his colleagues confirmed this with dramatic results in an animal model looking at Staphylococcus aureus osteomyelitis. They showed that the ability of immune cells to kill bacteria via what's called an oxidative burst was markedly decreased when the partial pressure of oxygen, the PO2, was very low, around 23 millimeters of mercury.
So basically ineffective at low oxygen.
Right. That killing ability improved as the PO2 increased to 45 and 109 millimeters of mercury, but it was most effective at 150 millimeters of mercury. So there's a clear dose-response relationship with oxygen. Higher PO2 equals a more powerful burst.
And what were the actual oxygen levels they measured in the infected bone in that study? That seems like a critical piece of data.
It really is. In that Mader study, animals breathing normal air at sea level had a mean PO2 of only 21 millimeters of mercury in their infected bone. In comparison, their uninfected bone was around 45 millimeters of mercury.
Well, less than half the oxygen in the infected area.
Yeah, but when these animals were put in a hyperbaric chamber and breathed 100% oxygen at 2 atmospheres absolute, the mean PO2 in the infected bone jumped to 104 millimeters of mercury, and in the non-infected bone, it reached 321 millimeters of mercury.
Okay, so a huge jump in the infected bone, from 21 up to 104.
Right. That significant increase gets it much closer to that 150 millimolar Hg threshold needed for optimal immune function. And subsequent animal studies by Esterhai reconfirm these findings, measuring mean oxygen tensions in infected bone around 16 millimolar Hg in air, but jumping to nearly 200 millimolar Hg at 2 ATA oxygen, and even higher, over 230 millimolar Hg at 3 ATA oxygen. The non-infected bone also saw big increases, confirming the effect.
Okay, so remember Mader's numbers. Compare them to Esterhai's. The pattern is clear. Hyperbaric oxygen dramatically boosts oxygen in infected bone. So mechanism 1. Hyperbaric oxygen boosts immune cell killing by increasing oxygen levels in the infected tissue. What else is going on?
A second important mechanism involves augmenting the transport of certain antibiotics into bacterial cells. The source explains that the transport of aminoglycoside antibiotics across the bacterial cell wall is both oxygen-dependent and significantly impaired in a hypoxic environment.
It sounds like the antibiotic can't even get into the bacteria effectively without enough oxygen. It needs help crossing the wall.
That's right. The active transport of antibiotics like gentamicin, tobramycin, and amikacin into bacterial cells relies on an oxygen-dependent electron transport chain within the bacteria. Think of it like a tiny metabolic engine that needs oxygen to run and pull the antibiotic across the cell wall.
Huh. I never thought about the bacteria's metabolism playing a role in antibiotic entry.
Yeah, and this transport is diminished if tissue oxygen tensions are below 20 to 30 millimeters of mercury. Therefore, hyperbaric oxygen exposures can enhance this electron transport, essentially powering up the bacteria's own uptake system to pull the antibiotic in, thereby augmenting the efficacy of the antibiotic action.
So HbO2 helps the antibiotics do their job better by helping them get inside the target. Does this synergy happen with other antibiotics?
Yes, the source specifically mentions a synergistic effect shown for the cephalosporin class of antibiotics as well. Studies demonstrated that the combination of cefazolin and hyperbaric oxygen therapy produced a 100-fold greater reduction in bacterial counts than using either the antibiotic or hyperbaric oxygen therapy alone.
100 times more effective. That's a dramatic level of synergy. Imagine multiplying the bacterial killing power by a factor of 100.
It really underscores why the combination can be so powerful. Comparable synergistic effects have also been demonstrated in localized soft tissue infections. One study by Sugihara et al. Showed a 46% reduction in infection resolution time, from a mean of 13 days down to only 6 days when hyperbaric oxygen therapy was combined with antibiotic therapy for soft tissue infections.
And that's relevant to bone infections, because
Well,
why focus on the soft tissue?
because infected soft tissues often act as pathways or conduits for initiating and sustaining infections in the outer layers of bone, the cortex. So, hyperbaric oxygen therapy's parallel benefit in helping clear those infected soft tissues may be crucial to its overall efficacy in resolving the underlying osteomyelitis. Imagine the infection traveling along a soft tissue highway into the bone. Cleaning up that highway is essential for long-term bone healing.
Okay, enhancing immune function, boosting antibiotic transport, and clearing soft tissue infection. What else is on the list? Are there other mechanisms?
Separately, the source notes that hyperbaric oxygen therapy has a direct suppressive effect on anaerobic bacteria. While it might seem counterintuitive to use oxygen against organisms that don't need it, hyperoxia can actually be toxic to certain anaerobes.
So too much oxygen is bad for them.
Right. And this is clinically important because anaerobes make up approximately 15% of the isolates found in chronic, non-hematogenous osteomyelitis. So it targets a significant fraction of potential culprits.
So it tackles a significant subset of the bacteria directly. What about effects on the bone itself? Does it help healing?
Yes, there's evidence that hyperbaric oxygen therapy enhances osteogenesis, which is the process of new bone formation. Animal data suggests that the rate of bone mineralization and overall healing can be accelerated by intermittent exposure to hyperbaric oxygen.
Okay, so promoting bone building.
Furthermore, the remodeling of bone, which involves breaking down old or damaged bone by cells called osteoclasts, is also an oxygen-dependent function. Inadequate oxygen tensions in infected bone can inhibit these osteoclasts, preventing the body's own microscopic debridement of dead or infected tissue.
So the cells responsible for cleaning up dead bone, the osteoclasts, need oxygen to work properly.
Exactly. And as we discussed, hyperbaric oxygen can restore physiological or even induce supraphysiological oxygen levels in those hypoxic bone environments, thereby enhancing osteoclast function in infected bone. This stimulatory effect on osteoclasts has been confirmed in animal models.
And the clinical benefit of that.
Clinically, this enhancement of osteoclast activity may improve the overall quality of bony debridement, especially since the line between healthy and necrotic bone isn't always clear to the surgeon's eye. Better microscopic cleanup by osteoclasts could reduce the chances of local infections recurring. Imagine those osteoclasts as microscopic surgeons, working better with more oxygen to find and remove dead tissue that the human surgeon might miss.
That image really helps. It's not just about killing bacteria, it's also about helping the body repair itself and clean up the mess.
Precisely. Finally, the source discusses the pathophysiology of chronic osteomyelitis, which is characterized by both acute and chronic sources of poor blood flow, or ischemia. Hyperbaric oxygen therapy has been shown to be effective in acutely reducing tissue edema swelling, lowering pressures within tissue compartments, and lessening the detrimental effects of inflammatory reactions. These are benefits that can be seen fairly early in treatment.
So immediate anti-inflammatory and anti-swelling effects. And what about longer-term improvements in blood flow?
Over the longer term, intermittent exposure to hyperbaric oxygen can promote new collagen formation. The building blocks of tissue and capillary angiogenesis, which is the sprouting of new tiny blood vessels, or neovascularization, in both the hypoxic bone and the surrounding soft tissues.
Angiogenesis, like growing new blood supply lines.
Exactly. This neovascularization helps counter the less easily reversible consequences of chronic infection and surgery, such as tissue scarring and occlusion of existing nutrient blood vessels. By creating a sustained increase in the arterial blood supply to previously hypoxic bone and soft tissues, hyperbaric oxygen therapy can potentially reduce the future susceptibility of these tissues to recurrent infection and necrosis.
So it's not just addressing the current infection, it's helping heal the underlying tissue damage and improve its future ability to fight off infection. It's building resilience.
Correct. It's addressing the environment that allowed the infection to take hold and persist in the first place.
That's a very comprehensive picture of the various ways hyperbaric oxygen therapy is proposed to work. Let's micro-recap these mechanistic rationales.
Okay, the mechanistic rationale for hyperbaric oxygen therapy in osteomyelitis centers on restoring oxygen levels in hypoxic infected bone. This elevation enhances the ability of immune cells like neutrophils to kill bacteria via oxidative mechanisms, particularly at partial pressures of oxygen around 150 millimeters of mercury.
Boosts the immune killing power.
Right. It also boosts the effectiveness of certain antibiotics, like aminoglycosides and cephalosporins, by facilitating their transport into bacterial cells, demonstrating significant synergy.
Makes antibiotics work better.
Hyperoxia directly suppresses some anaerobic bacteria. Furthermore, HBO2 promotes new bone formation, osteogenesis, and enhances the function of osteoclasts in debriding dead bone.
Helps rebuild and clean up.
And finally, it reduces acute inflammation and swelling while promoting long-term angiogenesis, improving blood supply and tissue health, which helps prevent recurrence.
Builds new blood vessels for lasting health.
Okay, knowing how it might work, the next crucial question is who is the right patient for this therapy? Let's move into patient selection criteria. Right. As we touched on in the intro, patient selection begins when standard therapy fails. The initial management of osteomyelitis depends on many factors. The timing of presentation, acute versus chronic, the source of infection, the specific organism causing it, how much bone is involved, and the overall health status of the patient, referred to as the host.
What does that initial standard management typically involve? Just remind us quickly.
Typical initial management starts with identifying the causative bacteria and initiating culture-directed antimicrobial therapy, choosing antibiotics specifically effective against that organism. Surgically, where present and accessible, standard practice involves debridement of infected sinus tracts, removal of hard dead bone called sclerotic bone, and excision of sequestra, which are pieces of detached dead bone. The source stresses that these debridement steps are crucial where indicated.
Getting the dead stuff out is key.
Absolutely. Some authors also suggest removing internal fixation hardware or other foreign materials that don't provide essential structural stability, as they can act as a persistent source of infection. However, there is clinical debate on this, particularly in complex spinal cases, where hardware removal is often undesirable if stability is maintained.
And we've seen advancements in surgery too, right? Things like grafts and frames.
Yes. The source briefly notes that advances in surgical techniques, such as using microvascular free muscle grafts to cover defects or employing complex procedures like Ilizarov frames to stabilize bone and facilitate healing, have helped decrease post-operative infection incidence in long bone fractures. However, these are often lengthy, complex, and expensive procedures themselves.
What kind of success rates does standard surgery and antibiotics achieve for primary non-refractory osteomyelitis, like when it works the first time?
The overall resolution rates reported in the literature for primary osteomyelitis treated with standard surgery and antibiotics alone range widely, from 35% to 100%. However, the source estimates that a more realistic 70% to 80% cure rate can be achieved using these routine techniques.
70 to 80%. That still leaves a significant chunk that doesn't get cured.
Exactly. Correspondingly, estimates for long-term osteomyelitis recurrence range between 20% and 30%. So even with standard best practice, a significant percentage of patients don't get a durable cure.
Okay, so it is precisely when appropriate surgical and antibiotic interventions fail to resolve the infection, when the osteomyelitis progresses, recurs, or presents such high risk that the probability for morbidity or mortality is significant, that adjunctive hyperbaric oxygen therapy should be considered for inclusion in the patient's treatment regimen. That failure of standard therapy is the main trigger for considering HBO2.
That's the core idea.
This brings us back to refining the definition of refractory. The source mentions differing clinical opinions on what constitutes appropriate interventions or accepted management techniques, which can make defining chronic or refractory purely by timeframes a bit fuzzy.
It can be. Classically, chronic osteomyelitis is distinguished from acute or subacute infections simply by exceeding an arbitrary time limit, typically cited as 4 to 6 weeks of clinical duration.
Okay, the classic 4 to 6 week mark.
Based on this classical view, osteomyelitis is considered refractory when it fails to respond to definitive surgical debridement and a period of 4 to 6 weeks of appropriate antibiotic therapy. The mechanistic reasoning behind this 4 to 6 week time frame is to ensure that antibiotic coverage is maintained long enough for surgically debrided bone to reestablish adequate blood supply or revascularize.
Are there differing opinions on that specific 4 to 6 week antibiotic duration? Is it always necessary?
Yes. While some authors advocate for longer courses of antibiotics, others argue that failure to resolve after 6 weeks of culture-directed therapy is more often due to inadequate surgical debridement, not getting out all the infected bone rather than simply an incomplete antibiotic course.
Uh, Blaming the surgery, not the drugs.
Well, sometimes. For example, if all infected bone is removed, as can sometimes happen in forefoot osteomyelitis, antibiotic therapy might be effectively shortened to as little as 10 days. It really highlights the crucial role of adequate debridement.
That reinforces the crucial role of surgery. What about the debate over intravenous versus oral antibiotics? Does it always need to be parenteral for that full period?
The traditional requirement for parenteral or intravenous antibiotics throughout the entire 4 to 6 week period has been questioned. A number of authors report equivalent success by switching from intravenous to oral antibiotic agents after 1 to 2 weeks in adult patients.
Oh, really? So oral switch might be okay sooner.
Potentially, yes. Comparable results have also been reported in children, although the source notes these studies primarily focused on treating acute rather than chronic osteomyelitis. Regardless of the route, what the source emphasizes as being more important is maintaining adequate antibiotic concentrations in the serum and in the bone throughout the 4 to 6 week coverage period, ensuring the antibiotic specifically targets the identified organism, and critically, the patient's compliance with the prescribed treatment regimen.
So it's about efficacy and adherence more than just the delivery method.
Got it.
What other factors besides time and failed treatment push a case towards being considered refractory?
The source points out that in addition to the failure of standard therapy over a certain time frame, the site of the infection and the overall medical status of the patient, the host, are crucial factors.
Site and host status.
Right. Osteomyelitis can be considered refractory before completing the traditional 4 to 6 week antibiotic period if the infection is not responding promptly, or if it involves sites that are critical to function and survival. These are the special indication sites we'll discuss further, such as the sternum, vertebrae, base of the skull, or other central bony structures.
So you might jump to calling it refractory sooner in those critical locations.
Exactly. This earlier consideration for refractoriness is particularly relevant when the patient's overall health is compromised by coexisting diseases, classifying them as a compromised host.
That leads us directly to classification systems that help guide which patients might benefit most. The source focuses on the Cyrenemator classification.
Yes, the Cyrenemator classification is a valuable tool for determining which patients are most likely to benefit from adjunctive hyperbaric oxygen therapy. While other classification systems exist, Cyrenemator is widely used because it functionally integrates 3 key elements: the cause of the infection, the anatomical location of the bone involvement, and the patient's overall physiology or host status into a single system that helps guide clinical treatment.
Can you walk us through how the Cyrenemator system categorizes both the bone involvement and the patient? Let's try to visualize this.
Certainly. The system first anatomically segregates the osteomyelitis into 4 distinct types. Imagine a diagram showing a cross-section of bone. Stage 1 is medullary osteomyelitis, where the infection is confined to the inner medullary cavity of the bone. Think deep inside the bone marrow space. It's often caused by bacteria entering the bloodstream or infected hardware placed inside the bone. Primary management typically involves antibiotics and possibly hardware removal if the infection is refractory and the bone is stable.
Okay, stage 1 inside the bone cavity.
Stage 2 is superficial osteomyelitis, an infection limited to the surface layers of the bone, the periosteum and cortical bone. Imagine infection just on the outside surface, maybe spreading from a wound above it. This often happens when an infection spreads from an overlying soft tissue wound where there's a break in skin coverage. Primary management involves antibiotics and superficial debridement of the infected bone surface and surrounding tissue.
Stage 2, just the surface.
Stage 3 is localized osteomyelitis, involving full-thickness infection of the cortical bone, often with sequestra, those pieces of dead bone. It's a contained but deep full-thickness area of dead bone. Typical causes include penetrating trauma or surgical contamination, especially with infected hardware. Primary management involves antibiotics, debridement of the necrotic bone and tissue, and the source notes adjunctive hyperbaric oxygen therapy is considered for refractory or progressive infections at this stage.
Stage 3, localized but through the cortex. HbO2 starts getting mentioned here.
Right. Stage 4 is diffuse osteomyelitis, which is the most severe. It involves infection throughout the entire bone thickness, often combining characteristics of stages 1, 2, and 3, with sequestra and significant mechanical instability of the bone, either before or after debridement. Imagine infection just rampant throughout the bone, making it unstable. Typical causes are similar to stage 3, often complex trauma or surgical contamination with hardware. Primary management requires antibiotics, extensive debridement, bone stabilization procedures, and adjunctive hyperbaric oxygen therapy for refractory or progressive infection.
Stage 4, diffuse, unstable, definitely considering HBO2.
Okay, so the stages describe the extent and location in the bone. Then there's the patient side, the host status.
Yes, the patient's host status is classified separately, as summarized in the source. An A host has normal physiology. They are generally healthy individuals without significant underlying medical conditions that would impair healing or immune function.
A host health. A B host is compromised. This is further subdivided. B sub S indicates systemic compromise, like diabetes, malnutrition. B sub L indicates local compromise at the infection site, like poor circulation, scarring. And B sub LS indicates both local and systemic compromise.
B host compromised either systemically, locally, or both.
A host is a patient for whom the treatment of the osteomyelitis, or the expected physiological outcome of that treatment, is considered potentially worse or more harmful than simply managing the ongoing disease. The source emphasizes this category is for patients where the treatment itself poses too great a risk.
C host treatment might be worse than the disease. Got it. And the source provides examples of those systemic and local factors that make a patient a B host. Can you give us a few?
Yes, systemic factors, B sub S, include conditions affecting the whole body. Malnutrition, kidney failure, diabetes mellitus, chronic low oxygen states, malignancy, immune deficiencies, immunosuppression, being at the extremes of age, or tobacco abuse.
Things affecting the whole body's ability to heal.
Exactly. And local factors, B sub L, affect the specific site of infection. Chronic lymphedema, venous stasis, major vessel compromise, arteritis, extensive scarring, tissue damage from radiation, small vessel disease, or complete loss of local sensation. Imagine constricted blood vessels, heavily scarred tissue, just impaired blood flow and healing right at the infection site.
So how does the Synergistic classification help guide the decision to use hyperbaric oxygen therapy? Where does it point us?
The source uses the classification to help predict who might benefit most. Stage 1 medullary infections are often primarily managed with antibiotics. Stage 2 superficial infections usually respond well to antibiotics and limited surface debridement.
So stages 1 and 2 usually don't need HBO2 initially.
Generally not. The patients identified as most likely to benefit from adjunctive hyperbaric oxygen therapy are those with more extensive disease. Stage 3, or especially Stage 4 osteomyelitis, particularly when complicated by adverse local or systemic risk factors, meaning they are B hosts. These patients are seen as benefiting from hyperbaric oxygen therapy used as an adjunct to continued antibiotics and often repeat surgical debridement.
So the complex infections, stage 34, in compromised patients, B hosts, are the prime candidates based on this system.
Yes, they are identified as having the highest likelihood of needing and benefiting from this adjunctive therapy. However, the source reiterates the fundamental principle. Synergistic staging serves as a helpful predictor of treatment success and guides approach, but regardless of a patient's specific classification, adjunctive hyperbaric oxygen therapy should be considered whenever the osteomyelitis proves either refractory or progressive, despite the application of standard of care interventions.
Okay. So the clinical reality trumps the classification.
Exactly. The clinical reality of failing standard therapy is the ultimate trigger. Even if the classification initially suggested standard care alone might suffice.
That's a crucial distinction. The classification helps, but clinical response is paramount. So if we were thinking in terms of a board-style question, which Synergistic stages and host types are most likely candidates for HBO2 therapy?
Based on the source material, the answer points towards patients with stage 3 or stage 4 osteomyelitis, particularly those who are also classified as B hosts, due to systemic or local compromising factors, especially when their infection has proven refractory or progressive despite receiving standard surgical and antibiotic treatment.
Excellent. Let's micro-recap this section on patient selection.
Okay. Patient selection for adjunctive hyperbaric oxygen therapy is typically triggered by the failure of standard therapy-appropriate surgery and culture-directed antibiotics for at least 30 days or approximately 4 to 6 weeks, resulting in no improvement or worsening.
Failure of standard care is the entry point.
Right. Factors like the infection site, critical structures, and the patient's health status, compromised hosts, can prompt consideration earlier. The Cyernimator classification system categorizes infections by anatomical stage, 1 to 4, and patients by host status, A, B, C, identifying patients with stage 3 or 4 disease, especially those who are B hosts, as likely candidates.
Cyernimator helps identify likely candidates, stage 34 B hosts.
However, the ultimate decision point is the clinical reality of refractory or progressive infection, despite standard of care interventions, regardless of initial classification.
But clinical failure is the ultimate trigger. Great. Now we know how it works and who might need it. Let's turn our attention to those specific special indications, the anatomic sites where osteomyelitis is particularly challenging and potentially life-threatening.
As we hinted at earlier, certain cases of refractory osteomyelitis demand special consideration due to their location near the central nervous system or other vital structures, and their potential for generating severe, rapidly progressing infections. These are sites where the stakes are exceptionally high.
Right, where things can go wrong fast.
Exactly. The specific areas of concern listed in the source are osteomyelitis affecting the sternum, vertebrae, cranium, and other central bony structures, including the skull base in cases like malignant external otitis.
Let's start with sternal osteomyelitis, which is a known complication after procedures like open-heart surgery.
Yeah.
That sounds pretty serious.
It is. Sternal osteomyelitis occurring after a median sternotomy incision is not uncommon, with incidence rates reported between 0.4% and 8.4%. However, despite often requiring extensive surgical debridement and complex procedures like muscle or tissue flap grafting to close the defect, it remains a condition with significant morbidity and can even be fatal.
So even with aggressive surgery, it's tough.
Yeah, recurrence rates after initial treatment range between 3% and 8%. Furthermore, while more aggressive surgical methods can sometimes eradicate the infection, they are associated with high mortality rates, tragically ranging between 20% and 35%.
20 to 35% mortality even with aggressive surgery. Those are very serious risks.
Yeah.
What about infections of the spine, vertebral osteomyelitis?
Complications from vertebral osteomyelitis are equally concerning. The source points out that fully 25% of individuals initially treated non-surgically with antibiotics alone for vertebral infections experience medical failure.
A quarter fail antibiotics alone.
Right. For the majority of these cases that fail medical management, extensive surgical debridement, which often includes the difficult and risky removal of retained spinal fixation hardware, has been described as necessary to eradicate the disease. Even with surgery, postoperative morbidity from vertebral osteomyelitis has been reported to be 29%, and mortality can be as high as 12%.
High morbidity and mortality there too. Moving up to the skull, cranial osteomyelitis.
Cranial osteomyelitis makes up a smaller percentage of all osteomyelitis cases, about 1.5%. However, it occurs in approximately 2% to 9% of patients following procedures like craniotomy. While the immediate direct surgical morbidity and mortality approximate 13% and 7% respectively, secondary mortality rates stemming from complications associated with cranial bone infections, such as the spread of infection to the brain causing meningitis or abscess, have been reported to be as high as 20% to 40%.
Wow, secondary mortality up to 40% from complications, that's huge. And finally, malignant external otitis, which the source calls a special subcategory.
Yes, malignant external otitis is a particularly aggressive, invasive form of osteomyelitis that tends to start in the external auditory canal and extend into the skull base. It can be lethal. Like other central bone infections, standard treatment involves antibiotics, local wound care, and where needed, surgical excision of necrotic tissue. Despite advances in antibiotic therapy, these approaches don't always achieve a complete cure, and overall mortality remains significant in the 10% to 20% range.
So across all these central sites, sternum, spine, cranium, skull base, the infections are inherently high risk, difficult to treat with standard surgery, and carry significant morbidity and mortality. The consequences of failure are severe.
That's the clear message from the source. For these central structure osteomyelitis cases, aggressive clinical management is absolutely vital to limit the devastating associated morbidity and mortality. Consequently, each of these specific indications has been studied and discussed independently in the literature, often earning special consideration in treatment guidelines and publications like the one we're reviewing.
They are highlighted because they are the cases where standard options are most problematic and the need for effective adjunctive therapies is most acute. Let's micro-recap the special indications.
Okay, the special indications for considering aggressive management, potentially including adjunctive hyperbaric oxygen therapy, are osteomyelitis infections involving critical central structures, the sternum, vertebrae, cranium, and the skull base, such as in malignant external otitis. These sites are challenging because infections there carry a significantly higher risk of severe morbidity, loss of function, and mortality, even when treated with standard aggressive surgical and antibiotic approaches compared to infections in less critical locations like the long bones of the extremities.
Understood. Critical locations demand special attention. Now that we've covered the definition, mechanisms, patient selection, and special sites, let's put it all together and discuss clinical management, the practical application of the Triad approach.
Right. As we noted in the section on patient selection criteria, the initial treatment strategy for osteomyelitis depends on how the patient's disease is classified. Generally, patients with cyraniomator stage 1 or stage 2 infections, which are less extensive, may be primarily managed with culture-directed antibiotics and limited surgical debridement.
But that approach needs augmentation for the refractory cases, especially those at higher stages or in compromised hosts. Those stage 3s and 4s, particularly the B hosts.
Exactly. In contrast, patients with refractory, more extensive disease, cyraniomator stage 3B, and particularly stage 4B osteomyelitis, should be considered candidates for adjunctive hyperbaric oxygen therapy. The source also mentions that if a different classification system is more relevant for a specific condition, such as the Wagner classification for diabetic foot ulcers or the Tisch classification for malignant external otitis, those systems can similarly be used to guide the decision to include hyperbaric oxygen therapy.
So use the appropriate classification system, but the underlying principle for considering HbO2 remains the same. And what does that principle determine again? Just to hammer it home.
Regardless of the specific classification system used, the principal determinant for adding hyperbaric oxygen treatment to the overall management of the patient's osteomyelitis is their clinical response to standard of care interventions. Is the infection improving as expected with antibiotics and surgery? Or is it stuck or getting worse? That's the key question.
If a patient is identified as a candidate for hyperbaric oxygen therapy, what's the recommended timing for initiating it, especially relative to surgery? Does it matter when you start?
It does. The source stresses the importance of ensuring culture-directed antibiotic therapy is current and effective. If not, it should be restarted or adjusted. That's step 1. For most cases of osteomyelitis in the extremities or at miscellaneous sites, the source states that initiation of hyperbaric oxygen therapy should coincide as closely as possible with planned surgical debridement prior to beginning the hyperbaric treatments.
So clean it out surgically, then hit it with HbO2 and antibiotics right away.
That's the idea for most cases. Apply the high oxygen environment to the freshly cleaned site.
But you mentioned a different timing approach for those special high-risk cases, the spine, the skull.
Yes, that's a critical nuance. In certain clinical settings, specifically osteomyelitis affecting children or bony structures adjacent to the central nervous system or other vital organs, are special indications like the spine or skull base. A trial of combined hyperbaric oxygen and antibiotic therapy should be considered prior to subjecting the patient to extensive surgical debridement or procedures associated with a high risk for morbidity or mortality.
Try HbO2 and antibiotics first, hoping to avoid the big surgery.
Exactly. It offers a potential chance to resolve the infection and avoid a highly morbid operation up front.
The source includes a helpful table summarizing the American Heart Association class recommendations for hyperbaric oxygen treatment for osteomyelitis based on the anatomic site and clinical setting. Can you describe the key aspects of that table and its recommendations? It sounds like a really useful guide.
Certainly. Table 3 in the source material is structured to guide clinicians, listing patient or site descriptors, the treatment components recommended alongside hyperbaric oxygen therapy, and the corresponding American Heart Association class recommendation. Remember, Class 1 is definitely recommended and accepted. Class 2A is reasonable and beneficial based on evidence weighted in favor. Class 2B is less well established but may be considered. And Class 3 is not recommended or may be harmful.
Let's look at some of the key recommendations from that table. Where does HbO2 stand for different situations?
Okay. For adult long bone or nonspecific osteomyelitis, when managed with hyperbaric oxygen therapy combined with antibiotics and surgical debridement, it receives a Class 2A recommendation.
Class 2A for long bones with the full triad.
For adult mandibular osteomyelitis, HbO2 plus antibiotics alone is Class 2B, but adding surgical debridement elevates it to Class 2A. Interestingly, for child mandibular osteomyelitis, using HbO2 and antibiotics before potentially disfiguring or debilitating surgery or amputation is given a Class 2A recommendation. This highlights the emphasis on avoiding morbid procedures in children if possible.
Class 2A for kids' jaws to try and avoid surgery. Makes sense.
Moving to the special sites. For spinal osteomyelitis, HbO2 and antibiotics alone is Class 2B, but combined with limited debridement, it's Class 2A. Cranial osteomyelitis with HBO2, antibiotics, and limited debridement is Class 2A.
So Class 2A for spine and cranial with limited surgery.
Right. For malignant otitis external, for the less severe TISH stage 1 or 2, HBO2, antibiotics, and debridement gets a Class 2B. But for the more severe, higher risk TISH stage 3 or 4, the same combination is Class 2A.
Stage dependent for MEO. Class 2A for the severe cases.
Exactly. Sternal osteomyelitis with HBO2, antibiotics, and limited debridement is also Class 2A.
Okay, sternal Class 2A2. And the highest recommendation in the table. Where do we see Class 1?
The highest recommendation, American Heart Association Class 1, is given for diabetic ulcers, Wagner grade 3 or 4 with associated osteomyelitis, treated with hyperbaric oxygen therapy, antibiotics, and limited debridement. That's a definitive recommendation based on the evidence for preventing amputation.
Class 1 for severe diabetic foot osteo? That's strong. So notice the Class 1 recommendation here for diabetic ulcers, and contrast that with the Class 2A recommendations for the other critical sites like sternal, spinal, and cranial osteomyelitis when combined with limited debridement.
Yes. So the classification system, the specific anatomic site, and crucially, whether HBO2 is used alongside surgery significantly influence the strength of the recommendation.
So the classification system, the specific anatomic site, and crucially, whether HBO2 is used alongside surgery, significantly influence the strength of the recommendation. Let's get back to the specifics of delivering the therapy. What about the treatment pressure? How deep do you go?
Determining the ideal hyperbaric treatment pressure is aimed at achieving the core mechanistic goal: restoring oxygen tensions in the infected bone to normal or above normal levels. As we discussed based on Mader's work, a target oxygen tension of at least 150 millimeters of mercury is recommended for optimal phagocytic function.
Got to hit that 1 in 50 mark for the immune cells.
Right. Animal data suggested a minimum pressure of 2 atmospheres absolute was necessary to achieve this goal. However, Mader's specific data showed bone oxygen tensions only reached 104 millimeters of mercury at 2.0 ATA, implying that pressures higher than 2.0 ATA might be needed to reliably reach that 150 millimeter HE target and maximize clinical effects.
So 2.0 ATA might not quite cut it based on that data.
It might be borderline in some cases.
What pressures were actually used in the human studies reviewed? Did they go higher?
The source reports that all clinical studies included in the review used hyperbaric oxygen treatment at pressures ranging between 2.0 and 3.0 atmospheres absolute. Interestingly, the studies associated with the most successful treatment responses tended to employ chamber pressures between 2.4 and 2.5 atmospheres absolute.
2.4 to 2.5 ATA seems like the sweet spot in the successful studies.
It appears to be, yes.
Is there a practical recommendation for clinicians starting HBO2 treatment? Board-style question. What pressure range is suggested for initiating HBO2 treatment in refractory osteomyelitis, and why?
The source suggests that because we don't have real-time, non-invasive ways to measure bone oxygen tension to perfectly titrate pressure, initiating hyperbaric oxygen treatment for refractory osteomyelitis at 2.4 to 2.5 atmospheres absolute may offer the best physiological balance. It aims for pressures likely to achieve adequate oxygen delivery to the bone based on the clinical studies, while minimizing the potential risk of oxygen toxicity compared to going higher, say to 3.0 ATA routinely.
That's a clear, practical guideline based on the available data. Find that balance at 2.4, 2.5 ATA. What about the duration of individual sessions and the frequency?
As we mentioned in the intro, there's some variability. Each individual hyperbaric oxygen treatment session is generally delivered over a period of 90 to 120 minutes. Most clinicians provide this therapy on a once-daily basis, typically 5 to 7 times per week.
Once a day, 90, 120 minutes. Seems straightforward.
However, the source notes that some protocols advocate for a more aggressive approach initially, with twice-daily treatment during the first 2 to 3 post-operative days.
Twice a day right after surgery. Why?
The goal of this more intensive start is to aggressively prevent bacterial recolonization right after surgery and to maximize other acute benefits of hyperbaric oxygen therapy, such as reducing ischemia, edema, inflammation, and reperfusion injury. Really hit it hard up front.
And this more aggressive initial approach is particularly relevant for those high-risk special indications, like the spine or sternum.
Yes. This more intensive initial treatment is also suggested in cases involving the central nervous system and other vital structures where rapid infection progression could lead to significant morbidity or mortality. Give it everything you've got early on.
How is the total number of treatments determined? It seems variable from the studies you mentioned earlier, from 14 to over 100.
It is quite variable. The total number of required treatments depends significantly on the severity and specific location of the infection, whether the patient has coexisting diseases, and their individual clinical responsiveness to the therapy. Studies reviewed range from as few as 14 to over 100 total sessions, with the majority reporting a range between 20 and 50 total sessions.
So there's no single number everyone gets. You can't just prescribe 30 sessions.
Exactly. Because of the wide variability in how patients present and the different concurrent management strategies used, specifying an exact fixed number of treatments isn't practical or appropriate. The source recommends that clinicians should carefully consider each patient's disease severity, their demonstrated clinical responsiveness, and their risk for infection recurrence when deciding on the total number of sessions. It requires individualized clinical judgment.
Tailor the treatment length to the patient's progress. Let's revisit the management approach based on how the patient responds to that initial treatment plan. Indicated surgery, appropriate antibiotics, concurrent hyperbaric oxygen. What if there's prompt clinical improvement? Things are looking good.
If that initial treatment regimen results in prompt clinical improvement, the source recommends continuing the antibiotic and hyperbaric oxygen therapy until the surgically debrided bone has had sufficient time to revascularize. As mentioned, this period of reestablishing blood supply usually corresponds to approximately 4 to 6 weeks.
So keep the combo going for that 4 or 6 week healing window.
Right. Depending on the frequency of hyperbaric oxygen sessions, this typically means delivering a total of 20 to 40 postoperative sessions during this interval. The assumption is that after this period, if there's no hidden pocket of infection, like retained dead bone or unsterile hardware, the bone environment should be sufficiently healthy to prevent the infection from coming back.
And for those special cases where extensive surgery or hardware removal isn't the initial approach, that trial period.
In cases where expensive surgical debridement or removal of fixation hardware is relatively contraindicated cranial, spinal, sternal, or pediatric osteomyelitis, the source reiterates that a trial of culture-directed antibiotics, hyperbaric oxygen therapy, and perhaps only limited surgical debridement, prior to considering more radical interventions, offers a reasonable prospect for osteomyelitis cure. Again, a course of 4 to 6 weeks of this combined therapy trial should generally be sufficient to see if the desired clinical results are achievable with this less morbid approach.
So that 4-6 week, 20-40 session window is key both post-op and for these preemptive trials. What if the patient is a compromised host, a B host, according to Mater? Do they need longer treatment? Does that change things?
Coexisting compromising factors, Mater B factors, may indeed slow down the expected rate of infection resolution. However, the source gives a specific caution here. Extending hyperbaric oxygen and antibiotic treatment beyond 1 to 2 more weeks past the initial 4 to 6 week mark is generally unlikely to provide definitive benefit if significant improvement hasn't occurred by then.
So there's a limit to how long you keep pushing if it's not clearly working, even in a compromised host. Maybe 6-8 weeks max for that initial course.
That seems to be the implication. Pushing beyond that without clear progress isn't likely to suddenly turn things around.
What's the plan if there's failure to resolve a recurrence after that initial period, say after a total of 6 to 8 weeks of continuous treatment, 30-40 sessions, if it's just not working?
As we discussed earlier, the source is very clear. If the osteomyelitis fails to resolve or recurs after a total of 6 to 8 weeks of continuous culture-directed antibiotics and hyperbaric oxygen treatment, then additional surgical debridement is likely required to eradicate any residual infected or dead bone that's serving as a nidus for the infection. Back to the OR, potentially.
And is hyperbaric oxygen therapy necessarily abandoned if more surgery is needed? Or can you restart it?
No, it's not abandoned. Subsequent to these treatment modifications, the additional surgery or necessary adjustments to antibiotic therapy, the accumulated clinical evidence suggests that reinstituting adjunctive hyperbaric oxygen therapy will again help maximize the overall chances of achieving resolution in these persistently refractory patients. It's brought back in to support the new surgical and antibiotic effort.
Okay. Fix the surgical antibiotic part, then bring HBO2 back to boost the revised plan. The source includes a flowchart, Figure 2, visually representing this management process. Can you describe the flow and decision points? Walk us through it.
Okay, imagine a branching decision tree. It starts with identifying refractory osteomyelitis. Is the bone infection not responding after that initial 4 to 6 weeks of standard care?
Yes, no. If no, continue standard care. If yes,
You move to a critical step. You must reevaluate and refine the antibiotic coverage, ensuring it's culture-directed and effective, and restart or adjust the antibiotic regimen.
always check the antibiotics first. Then,
From there, the path splits based on whether extensive surgical debridement or hardware removal is contraindicated or significantly complicated by the anatomic location, like our special indications. Is surgery complicated or high risk?
yes, no again. If yes, surgery is risky.
The recommendation is to initiate 4 to 6 weeks of HBO2 therapy concurrent with the reevaluated antibiotics, perhaps with limited debridement. Try the less invasive route first.
Okay, and if no, surgery is feasible.
You proceed with surgical debridement and a hardware removal first, and then initiate HBO2 concurrent with the reevaluated antibiotics after the surgery. Surgery first, then HBO2 support.
Got it. After either path.
After either of these paths, initiating HBO2 plus limited surgery or proceeding with more definitive surgery plus HBO2, the flowchart asks the crucial question: osteomyelitis resolved?
Resolved? Yes, no. If yes.
And provided the patient's overall status doesn't make further treatment more harmful than the disease itself, addressing the C-host concept is treatment worse than the disease, you stop HBO2 and continue wound care as needed. Success.
Okay. But if the osteomyelitis is not resolved.
The chart again considers if continued treatment is worse than the disease, the C-host decision. If yes, the approach becomes more palliative. If no, you loop back to the step of reevaluating and refining antibiotic coverage and considering additional surgical debridement before potentially reinstituting HBO2 therapy with the optimized plan.
So failure loops back to reassessing surgery and antibiotics before trying HBO2 again.
Exactly. It clearly shows that failure triggers reassessment of surgery and antibiotics before discontinuing or restarting HBO2. You don't just repeat the failing HBO2 course.
That flowchart really encapsulates the process. Rule out treatable causes with standard therapy first, then layer in HBO2 appropriately, and if it still doesn't work, go back to the fundamental surgery and antibiotics before trying HBO2 again. Let's do a micro recap of clinical management.
Okay. Clinical management hinges on identifying refractory or progressive infection after standard therapy, typically 4 to 6 weeks of antibiotics plus surgery, using classification systems like Cernimator or Wagner as guides, but prioritizing clinical response.
Identify failure, use classifications, but response is key.
Culture-directed antibiotics are essential. HBO2 is usually timed with surgical debridement, but for critical sites or children, a trial before expensive surgery is considered.
Antibiotics critical, timing HBO2 with surgery usually, special timing for critical site skits.
Treatment parameters: 2.4, 2.5 ATA, 90-120 min sessions, usually once daily, 5-7 days a week. A typical course is 4-6 weeks, 20-40 sessions if responsive.
The standard dose and duration.
If response is poor or recurrence occurs after this initial period, do not continue the same regimen. Instead, reassess and modify surgical and/or antibiotic strategies without delay, and then potentially reinstitute HBO2 with the revised plan.
If failing, stop, reassess surgery antibiotics, then maybe retry HBO2. Great. Now that we've laid the groundwork, let's examine the studies that inform these recommendations. What does the evidence-based review reveal? What's the data really say?
The source provides an evidence-based review based on an updated methodology incorporated into the UHMS Hyperbaric Oxygen Therapy Indications 14th edition. The review was based on online searches using hyperbaric oxygen and osteomyelitis, which yielded an initial pool of 293 articles published from 1965 onwards.
Okay, a broad search. How were these articles filtered down for the review? What made the cut?
Of the articles in English, 106 contained original data on the hyperbaric oxygen treatment of osteomyelitis in humans, 96 articles for animals, 10 articles. The rest were excluded for various reasons. They were literature reviews in a foreign language, reported data previously published, didn't involve systemic hyperbaric oxygen therapy, mixed hyperbaric and non-hyperbaric data without clear distinction, or were single-case reports with fewer than 3 patients.
Standard filtering criteria. So how many studies actually got evaluated?
After applying these inclusion and exclusion criteria, a total of 44 studies, 9 animal and 35 human, remain for evaluation according to American Heart Association guidelines.
Okay, 44 studies. Let's start with the animal studies. What was the quality like and what did they show? Any major takeaways?
The quality of the 9 prospective animal studies examining the effects of hyperbaric oxygen on experimentally induced bone infection was considered overall good, with 3 studies noted as having excellent methodological design. A key limitation, however, was that none of these studies included concurrent bony debridement as part of the management protocol, which, as we've discussed, is often essential in clinical refractory osteomyelitis.
So they didn't replicate the full triad in the animal models. That's important.
It is. This misses an important parallel with real-world treatment.
Despite that limitation, what data did the animal studies contribute to our understanding? Did they support the mechanisms?
Yes. From a mechanistic standpoint, as noted, Esterhai's work provided early objective evidence demonstrating that hyperbaric oxygen increases intramedullary oxygen tensions to levels required for normal immune cell function. Two early studies also reported increases in bone healing with HbO2. Hamblin showed significantly higher primary healing rates, and Triplet demonstrated improved fracture stability compared to controls.
So boosted oxygen, better healing.
However, a 2012 study by Shanley et al. Evaluating HbO2 alone for implant-associated long bone osteomyelitis showed a neutral effect on bacterial counts, reinforcing that HbO2 is not a standalone antibacterial therapy, especially without antibiotics or debridement.
Right. Doesn't kill bacteria on its own.
Exactly. In contrast, 5 animal studies prospectively evaluated the complementary effect of combined HbO2 and antibiotic therapy on bacterial growth. Each of these reported a statistically significant benefit, improved wound healing, and/or decreased bacterial colony counts when HbO2 was added to antibiotics compared to controls.
Okay, HbO2 plus antibiotics works better than controls.
And the 2 most recent studies demonstrated significant synergy between HbO2 and antibiotics, showing drastically reduced bacterial counts compared to either therapy alone, for example, reducing colony counts by factors of 10 to the power of 2 to 10 to the power of 6 over several weeks of treatment. Imagine bacterial numbers just plummeting by orders of magnitude.
Those numbers, even in animals, suggest a powerful combined effect. But what happens when you bring in the surgery, completing the triad? Did any animal study do that?
Perhaps the most important finding from this animal data came from Mendel, who showed that when hyperbaric oxygen therapy was combined with antibiotics and surgical debridement of overlying infected soft tissues, complete eradication of osteomyelitis could be achieved in the animal model.
So the triad achieved complete eradication in the animal model. That strongly supports the rationale for the triad approach in clinical practice.
It does. The conclusions from these controlled animal trials are clear. While neither antibiotics nor hyperbaric oxygen alone consistently eliminate bacterial growth in infected bone, the synergy between them produces significant bacterial reductions. But the most efficacious results are achieved when hyperbaric oxygen and antibiotics are combined with surgical debridement. Thus, the cumulative animal data suggests that a management triad, culture-directed antibiotics, thorough surgical debridement, and concurrent hyperbaric oxygen therapy is the strategy most likely to achieve clinical cure in refractory osteomyelitis. It's the triad of success working together.
The triad of success, I like that. That's compelling evidence from the lab. Now let's turn to the human studies. What's the quality of this data like? Is it as strong?
Unfortunately, no. The source acknowledges that the quality of available human study data is a significant limitation. The vast majority, 29 out of 37 reports, were clinical case series, which are classified as American Heart Association Level 5 evidence, the lowest quality, essentially descriptive reports without comparison groups.
Level 5. So mostly just descriptions, not comparisons. That's weak.
It is. Only 6 studies use non-randomized cohorts, 3 studies, or actual control groups, 3 studies, achieving slightly higher American Heart Association Level 4 and Level 3 classifications, respectively. Still, no Level 1 or 2 evidence from randomized trials.
So mostly observational, lower quality evidence for humans. What was the overall judgment?
Yes, the overall quality was judged as intermediate, somewhere between fair and good on the AHA scale. 6 were considered excellent or good in design, but 17 were less well-designed. When looking specifically at the 27 studies reporting on refractory osteomyelitis, the median quality was assessed as good, but still heavily reliant on case series.
What challenges make it hard to draw firm conclusions or directly compare different clinical management strategies in these human studies? Why is it so messy?
The source lists several confounding factors inherent in human osteomyelitis studies. Significant variations in the extent and location of the bone involvement, the specific bacteria causing the infection, the patient's coexisting medical conditions, and the specific strategies used for antibiotic and surgical intervention across different studies.
So much variability between patients and treatments.
Exactly. Furthermore, different studies use different definitions or terminology for outcomes like cure, arrest, improvement, or failure, which further complicates interpretation. Apples and oranges sometimes.
So Trying to compare outcomes across studies is difficult because the patients and treatments vary so much, and even how success is defined can differ. It's hard to pool the data meaningfully.
Exactly. The source points out that these challenges aren't unique to hyperbaric oxygen studies. They are common to all osteomyelitis treatment modalities. It cites a comprehensive review by Lazzarini et al. Of 93 clinical trials on antibiotic therapy for osteomyelitis, which concluded that the available literature is inadequate to determine the best antibiotic agent, route, or duration.
Wow, even for antibiotics, the evidence isn't definitive.
It underscores that osteomyelitis is a complex disease, inherently difficult to study with high-level, definitive trials.
Given these limitations, how should we interpret the findings from the human studies on hyperbaric oxygen therapy? How do we make sense of it?
The source suggests interpreting the perceived benefit by considering that most clinical series evaluating hyperbaric oxygen therapy for osteomyelitis are conducted in patients who have already failed standard management with antibiotics and for surgery. Therefore, the relative benefit of adding hyperbaric oxygen therapy to renewed standard therapies becomes more apparent when viewed in the context of previous failure.
So look at it as a salvage therapy for cases where standard care didn't work.
Essentially, yes, it's looking at outcomes in a population where the alternatives have already proven insufficient.
Let's look at some of the specific cohort and controlled trials cited in the source, even recognizing their limitations. What did they find?
In a large non-randomized series of 689 patients with osteomyelitis, Kawashima compared outcomes between those receiving standard care, antibiotics, debridement irrigation, and those receiving adjunctive hyperbaric oxygen therapy. While both groups had high rates of good outcomes, 88.3% non-HbO2 versus 91.9% HbO2, the difference was statistically significant. However, the source notes limitations like unclear definitions of good and potential differences between the groups that weren't accounted for, limiting the strength of the conclusion.
Okay, a large study, statistically significant difference, but methodological concerns.
Right. Roger Ray published a large retrospective analysis of 388 patients with severe open war wounds, often precursors to osteomyelitis. They found that osteomyelitis developed less frequently in patients who received HbO2 as part of initial wound management, 63%, compared to those who didn't, 74%. While this study looked at HbO2's role more in preventing osteomyelitis in high-risk wounds rather than treating established refractory disease, the results in complex long bone infections are still considered noteworthy.
Interesting. A potential preventative role in high-risk trauma. Let's look at the U et al. Study on sternal osteomyelitis again, as it was highlighted for potential benefits. What were those key findings?
Weir et al., in a retrospective analysis of 12 patients with sternal osteomyelitis after cardiac surgery, compared 6 patients treated with antibiotics and debridement plus HbO2 to 6 case-matched controls who received only antibiotics and debridement. While the number of surgeries or total hospital stay didn't differ, the HbO2 group saw significant clinical benefits. Reduced length of stay in the intensive care unit, an average of 8.7 days versus 48.8 days.
Wow, 8 days versus 48 days in the ICU.
Shorter duration of mechanical ventilation or positive pressure support, 4 days versus 34.8 days. And importantly, reduced overall mortality, 0 deaths in the HbO2 group versus 3 deaths in the control group.
0 deaths versus 3 deaths. That's powerful data showing a significant impact on critical care needs and survival for a very difficult infection site. Board-style question. What specific outcomes were significantly improved with HbO2 in the U et al. Sternal osteomyelitis study?
The key improvements were significantly shorter ICU stays, less time needing mechanical ventilation or positive pressure support, and reduced overall mortality.
Critical care and survival benefits. Now, what about the Esterhazy study, which reported no benefit? Why was that considered less reliable?
In a non-randomized prospective study of 28 patients with tibial infections, Esterhazy et al. Reported no benefit from adjunctive hyperbaric oxygen. However, the source points out that this study had significant limitations. Particularly, many patients refused to undergo necessary surgical debridement, which likely impaired the overall treatment success and limited the study's statistical power to detect a difference.
So they couldn't properly test the triad because patients refused the surgery part.
Exactly. And with a very high cure rate, even in the non-HbO2 group in this specific study, it's also...
Is there a more rigorous study providing stronger evidence for HbO2 in refractory osteomyelitis, one that did implement the triad better?
Yes, the source highlights the prospective trial by Barilli et al. On 32 patients with postoperative sternal infections as providing the most rigorous evidence available to date. Although not randomized, the two groups, 14 receiving HBO2, 18 controls, were well matched. All patients were considered to have severe Cernimator class 4 equivalent infections.
Okay, a prospective well-matched study on severe sternal infections. What did Bareilles find?
Bareilles found that adding HBO2 resulted in significantly lower infection relapse rates, 0% in the HBO2 group versus 33.3% in the control group.
Zero relapse versus a third relapsing. That's huge.
Furthermore, the HBR2 group required significantly shorter durations of intravenous antibiotic therapy, 47.8 days versus 67.6 days, and had significantly shorter total hospital stays, 52.6 days versus 73.6 days.
Shorter antibiotics, shorter hospital stay, and significantly reduced relapse. That's a strong case for sternal infections.
Because this study focused on a single infection site with a consistent surgical approach, it had greater power to detect a treatment effect and strongly documents improvements in clinical outcome when HBO2 is added to standard care for this difficult refractory infection. It's a key piece of evidence.
Okay, Bareilles' study is a cornerstone here. What about other sites? You mentioned Onen et al. For spinal infections?
Yes, Quonen et al. Evaluated 19 patients with spinal infections that were refractory to at least 3 weeks of antibiotics. With an average of 20 hyperbaric oxygen sessions plus continued antibiotics, all 19 spinal infections resolved. Importantly, no surgical revisions or removal of hardware were required in any of the patients who had instrumentation.
Achieving 100% resolution in refractory spinal infections, often without removing hardware, is a remarkable finding given the risks of spinal surgery. That sounds almost too good to be true.
It certainly is a striking result, suggesting a powerful effect in that specific context. Coulson and colleagues reported on 8 patients with diabetic foot ulcers complicated by osteomyelitis refractory to at least 4 weeks of standard care. Combining intravenous vancomycin with 40 HBO2 sessions, they achieved osteomyelitis resolution and ulcer healing in 75% of these previously failing patients. The 2 failures were noted as non-compliant.
Okay, 75% success in refractory diabetic foot osteo. And finally, the 2018 systemic review by Savidou et al., pulling together multiple studies. What was the overall success rate there?
Savidou et al. Analyzed 45 studies reporting on 460 patients with chronic osteomyelitis who had already received antibiotics and debridement. They found that adjuvant HBO2 was effective in 80% of cohort studies and 95% of case studies. Overall, in patients with complete data, 308 out of 419, 73.5%, had a successful outcome with no reported relapse.
So even with the inherent limitations of studying osteomyelitis and the lower quality of much of the human data, a consistent signal appears across numerous studies, suggesting a benefit when hyperbaric oxygen therapy is added, particularly in patients who have already failed standard treatment. It seems to work more often than not in these tough cases.
That's the overall impression from the cumulative evidence. Despite the lack of definitive, high-level randomized controlled trials, the trend is consistently positive.
Let's take a quick micro recap of the evidence base presented so far.
Okay. The evidence review, based on 9 animal and 35 human studies, highlights strong animal data supporting the synergistic triad of antibiotics, surgical debridement, and HBO2 as most effective, showing dramatic bacterial reductions when combined.
Animal data supports the triad.
Human studies are predominantly lower quality AHA level 5 case series, making definitive conclusions difficult due to variability. However, several cohort and controlled trials, particularly Bareilles for sternal osteomyelitis, Yu et al. For sternal, and Onen et al. For spinal, suggest significant benefits.
Key human trials show promise despite limitations,
including reduced relapse, shorter hospital ICU stay, reduced ventilation, decreased mortality, and even infection resolution without hardware removal. A large systemic review found an overall success rate of 73.5% in refractory cases treated with adjunctive HBO2.
Systemic review shows about 74% success overall.
Despite study limitations, the cumulative evidence generally supports HBO2 as a beneficial adjunct in previously failed cases.
We'll continue our exploration of the human study findings, focusing on site-specific results. Let's start with long bone and miscellaneous sites in more detail. Where did the early reports point?
The earliest reports on HBO2 for osteomyelitis often included long bones, Slack et al. In one of the early series on 5 patients treated with antibiotics, and HBO2 reported an 80% response rate, though it was a mix of chronic and refractory cases with varied concurrent treatments. Welsh et al. Similarly reported 80% healing in 5 patients with assorted site infections using HBO2 plus antibiotics, but specifics on refractoriness and other treatments were unclear. Host speaker. So, early signs were positive but lacked precision. What did later authors focusing specifically on refractory long bone cases find? Were the results better defined? Perrins et al. Treated patients who had previously failed conservative management, combining HBO2, average 20 days, with antibiotics and occasional sequestrectomy. They achieved complete healing in about 79% and overall cure, including follow-up, in 62% of refractory cases. Variability in debridement and sites limited this study, though.
Around 60–80% success, but still messy data.
El Torre et al. Showed HBO2's utility in 44 spinal cord injured patients with osteomyelitis, resolving infections and healing wounds in 2/3, notably without surgical debridement in conjunction with HBO2 treatments. Failures were linked to vascular disease. Importantly, all 5 cases of spinal osteomyelitis in this series cleared despite the lack of debridement, a seminal finding corroborated elsewhere, as we discussed.
Interesting. Success without debridement in that specific spinal cord injury group.
Bingham and Hart examined 70 patients with mixed refractory sites, including long bones, reporting an overall clearance, arrested or improved, of 61%. They noted differences by location. Tibial infections had higher arrest rates, 73% than femur, 40%, or hip, 38%. Concurrent antibiotics were used, but concurrent debridement wasn't consistently detailed.
So early results were mixed, location seemed to matter, and often HBO2 wasn't used with concurrent surgery. What happened when more definitive data on the combined approach emerged for long bones? The Triad approach.
Mori et al. Provided more definitive data in 40 patients with long bone osteomyelitis that had failed extensive prior treatment, an average of 3 or more surgeries and antibiotics over 30 months. These were really tough cases.
The truly refractory ones.
Exactly. When these highly refractory patients were started on a new course of parenteral antibiotics, underwent surgical debridement, and concurrently received an average of 42 HBO2 sessions, 85% were disease-free at 23 months, and 75% maintained resolution at 7 to 10 years.
Okay, 85% short-term, 75% long-term success after failing multiple prior surgeries antibiotics. That study strongly suggests HBO2 adds significant value in the truly refractory population when combined with renewed surgical effort.
Absolutely. It highlights the importance of adding HBO2 to a fresh, optimized surgical and antibiotic attempt. Davis et al. Similarly reported on 38 refractory long bone cases that had failed at least one previous surgery and antibiotics. With an average of 45 HBO2 sessions combined with debridement and antibiotics, 89% were infection-free after nearly 3 years mean follow-up.
Nearly 90% success in another refractory series with the Triad.
Chen and colleagues looked at 10 hemodialysis-dependent patients with diffuse tibial humeral infections who were also refractory. Combining surgery, antibiotics, and 20 HBO2 sessions led to resolution in 80% of these systemically compromised patients, with only 2 requiring amputation. Even in a challenging patient population, high success was possible.
Good results even in dialysis patients.
Skek et al. In 2015, reported on 23 patients with refractory non-diabetic ulcer-related bone infections, achieving eradication or improvement in 82.6%. Details on the nature of improvement weren't available, though. We noted Esterhai's negative study earlier, but it bears repeating that its power was limited by patient refusal of surgery, making it less informative about the efficacy of HBO2 when used appropriately with debridement.
Right. Can't blame HBO2 if the needed surgery wasn't done. What about combining HBO2 with advanced reconstructive surgery, like muscle flaps?
Maynor et al. Combined HBO2 with autogenous microsurgical muscle transplantation in patients with refractory tibial osteomyelitis who had failed an average of 8.3 previous surgeries. They also had a new debridement and antibiotics concurrent with HBO2, average 35 sessions, and many received vascularized muscle flaps. At 3 months, 82% were drainage-free, with sustained resolution rates around 80% up to 60 months, though dropping to 63% at 84 months, possibly due to late recurrence or statistical factors like loss to follow-up.
So good results initially, maybe some drop-off long-term, but still impressive after so many prior failures. And the prospective trials from Taiwan, they sounded promising.
Orthopedic surgeons at Changgung Memorial Hospital conducted 3 prospective trials specifically on refractory long bone osteomyelitis using strict criteria: persistent infection for at least 6 months, failure of at least 3 previous surgeries, and concurrent parenteral antibiotics with each attempt. All were centimeter stage 3 or 4.
Very specific, very refractory patients.
Yes. They consistently reported high success rates with surgical debridement, parenteral antibiotics, and adjunctive HBO2. 86% resolution in 1 tibial series, AVG 26 HBO2 sessions, no recurrence at 17 months, 79% in another tibial series, and 92% in a femoral series. e.g. 50 HbO2 sessions, no recurrence at 22 months. While not controlled trials, the specificity of the patient population and their documented failure of extensive prior standard treatment strongly support the benefit of adding HbO2 within this combined approach.
Consistent high success rates from that center using the Triad in tough cases. That's a lot of data points for long bone and miscellaneous sites. What's the summary of the findings in the corresponding American Heart Association class recommendations? How does it all shake out?
Okay, based on the review, for refractory osteomyelitis involving long bones and non-specified sites, using combined HbO2 and antibiotics alone without adequate surgical debridement appears to achieve cures in approximately 60% to 70% of cases. However, this is generally not superior to the expected 70% to 80% primary cure rates achievable with standard surgery and antibiotics alone in a primary infection.
So HbO2 plus antibiotics alone isn't better than standard primary care.
Right. Therefore, in the absence of concurrent adequate surgical debridement, HbO2 alone, or with antibiotics, generally garners only an American Heart Association Class 2B recommendation for these sites and is not a preferred alternative to repeat surgical debridement.
Class 2B without the surgery.
In contrast, when hyperbaric oxygen therapy is combined with appropriate antibiotics and concurrent surgical debridement in these refractory long bone and miscellaneous sites, overall cure rates range between 80% and 90%. These outcomes meet or exceed those reported for standard care alone in this difficult, previously failing population.
80 to 90% with the Triad in refractory cases. That's much better.
Yes. Thus, hyperbaric oxygen therapy should be considered an American Heart Association Class 2A intervention when combined with timely surgical debridement and appropriate antibiotic treatment.
Class 2A with the full Triad.
Furthermore, for patients with a refractory osteomyelitis facing potential extremity amputation or similarly debilitating surgery, a trial of adjunctive hyperbaric oxygen therapy combined with limited surgical debridement and continued antibiotics prior to undertaking those radical resections is also considered an American Heart Association Class 2A intervention.
Also Class 2A if you're trying to save a limb. So for long bones, the key distinction is whether HbO2 is used with adequate surgery. Without it, it's only Class 2B. With it, especially in refractory cases or to potentially avoid amputation, it's Class 2A. The Triad is essential for the higher recommendation. Let's micro-recap the evidence for long bone and miscellaneous sites.
Okay. Evidence for long bone and miscellaneous site osteomyelitis indicates that HbO2 plus antibiotics alone may achieve 60–70% cures, but this is not superior to standard care's primary success rates. Thus, without concurrent surgical debridement, it's a Class 2B recommendation.
HbO2 plus antibiotics alone, Class 2.
However, when HbO2 is combined with appropriate antibiotics and concurrent surgical debridement, cure rates in refractory cases rise to 80–90%. Earning an AHA Class 2A recommendation. This Class 2A recommendation also applies for patients facing potential amputation or debilitating surgery, suggesting a trial of HbO2 with limited surgery and antibiotics beforehand.
HbO2 plus antibiotics plus surgery, Class 2A, especially if refractory or trying to avoid amputation. Got it. Let's continue our site-specific review with mandibular osteomyelitis, the jawbone.
Reviewing the literature on mandibular osteomyelitis shows a wide range of outcomes, from 30% to 100% cure rates, reflecting variability in protocols and patient factors. Regarding hyperbaric oxygen therapy specifically for jaw infections, Jamil reported on 16 patients with treatment-resistant infections. HbO2 alone resulted in lasting resolution in only 6 of 16 patients.
37%.
Only 37% with HbO2 alone. That's pretty low.
It is. This low success rate with HbO2 as monotherapy is consistent with findings for long bone osteomyelitis, reinforcing that it's generally not effective by itself for established bone infection. What about combining HbO2 with antibiotics for the mandible? Does that help?
Hanschel looked at HbO2 alone for mandibular osteomyelitis. In patients without prior antibiotic treatment, success was 54%. But in those already refractory to antibiotics and surgery, only 44% were relapse-free with HbO2 alone. However, they noted superior results in younger patients. In a small subset of children refractory after antibiotics alone, 75% had sustained resolution with HbO2.
Maybe works better in kids.
Possibly. Lentrot's experience in 3 other refractory children also supports this, showing 100% cure with HbO2 and antibiotics. This seems to confirm a potentially differential response in younger patients.
So HbO2 plus antibiotics seems more promising in children's jaw infections than in adults, and better than HbO2 alone. What happens when surgery is added to the mix for the mandible? The full Triad again.
Control of mandibular osteomyelitis significantly improves with the trimodal approach of surgical debridement, antibiotics, and hyperbaric oxygen therapy. Manus et al. Reported resolution in 23 of 24 patients, 96%, using this combination, though they didn't distinguish primary from refractory cases.
96% is impressive.
Van Merkestein's series of 16 patients directly highlighted the difference. Only 1 of 9, 11%, improved with HBO2 and antibiotics alone by modality therapy, while 7 of 7, 100%, were cured when decortication, a type of bone debridement, antibiotics, and HBO2 were used concurrently. Trimodality therapy.
Wow. 11% versus 100% in the same study just by adding the surgery. That comparison within a single study is very compelling, a huge jump in cure rate by adding the surgical component.
It strongly supports the necessity of the surgical pillar of the triad for mandibular osteo2. They concluded that for refractory osteomyelitis, the coordinated use of HBO2, antibiotics, and surgery offered the best chance for cure.
Seems undeniable based on that.
The source also mentions Ida Solo's approach, using 10 preoperative plus 5-7 postoperative HBO2 sessions with antibiotics for refractory cases, achieving 79% resolution. While fewer total sessions than typical, this highlights the benefit of sequencing HBO2 and antibiotics around the surgical intervention, even if it's done before the main procedure. It supports the trimodal approach and suggests flexibility in timing.
What are the overall recommendations for mandibular osteomyelitis based on this evidence? Summarize the classes for us.
Okay. Based on these series, hyperbaric oxygen therapy cannot be recommended as a monotherapy for mandibular osteomyelitis. That's an American Heart Association Class 3 recommendation.
Class 3 for HBO2 alone. Never do that.
Right. When combined with antibiotics in the treatment of adult primary or refractory mandibular osteomyelitis, it receives an American Heart Association Class 2B recommendation.
Class 2B for HBO2 plus antibiotics in adults.
However, in child and adolescent patients, given the high potential for disfigurement and impaired bone growth from aggressive surgery, a trial of hyperbaric oxygen therapy and antibiotics prior to undertaking major debridement surgery is considered an American Heart Association Class 2A intervention.
Class 2A for kids' jaws to try and avoid surgery.
For adults, treatment of refractory mandibular osteomyelitis with the combination of antibiotics, surgical debridement, and hyperbaric oxygen therapy appears to maximize the potential for infection clearance. Although wide variability exists, the source notes that the lack of consistently successful alternative treatments for truly refractory mandibular osteomyelitis earns this trimodality approach an American Heart Association Class 2A designation.
Class 2A for the combined surgery plus antibiotics plus HBO2 approach in refractory adults, partly due to the difficulty of these cases and lack of other great options. So Class 3 for monotherapy, Class 2B with antibiotics in adults, Class 2A in children avoiding surgery, Class 2A with the Triad in adults. Let's transition now to spinal osteomyelitis. It sounds particularly tricky.
It is. What are the outcomes with standard antibiotic therapy alone for spinal infections? Priest studied 44 patients with vertebral osteomyelitis treated with antibiotics alone and found that 27% failed this conservative approach. By extending antibiotic coverage to over 140 days, he was able to cure 83% of infections, but half of the treated patients still had lingering effects from the infection.
So long antibiotics might work, but often leave problems. And with surgery plus antibiotics, how does that fare?
Kovalenko achieved a high 91% cure rate for hematogenous osteomyelitis with radical reconstructive surgery, but this still carried a 6% recurrence rate and 2% mortality. In more complex cases involving spinal fusion, Talmy reported only 66% resolution using combined surgical debridement and antibiotic therapy, even with drainage and hardware removal in some cases. Chen also reported refractory deep space infections after spinal instrumentation with an 11% recurrence rate despite extensive debridement, antibiotics, and continuous irrigation.
These highlight the significant challenges and risks, especially when spinal hardware is involved. Surgery is tough and doesn't always work. How do these outcomes compare to cases treated with adjunctive HBO2?
In contrast, Elterai et al. Reported 100% eradication using HBO2 and antibiotics in 5 cases of adult lumbar osteomyelitis. Ahmed et al. Used adjunctive HBO2 to treat 6 patients with complicated spinal osteomyelitis that was refractory or progressive despite antibiotics. Combining HBO2 with continued antibiotics and hardware work in 2 cases, they achieved resolution in 5 of 6 cases with no recurrence reported during follow-up.
High success rates, even without surgery in some cases.
Larson also reported on 7 patients with osteomyelitis after spinal surgery and instrumentation. After an average of 30 HBO2 sessions plus antibiotics, all 7, 100%, resolved their infections. Notably, spinal fixation hardware was left in place in 5 of 7 patients, 71%.
Hardware maintained in over 70% of cases.
Yeah.
That's significant.
It is. The source highlights that this non-operative approach compares favorably with other reports, and that the lack of recurrence after adjunctive HBO2 treatment exceeds the recurrence rate seen with antibiotics alone or surgery plus antibiotics in some series.
And that remarkable success of avoiding surgery in instrumented spines was extended by Oman et al.'s study. Remind us of those results.
Yes, Mullen et al. In 2015 reported on 19 adult patients with iatrogenic spinal infections that were refractory to at least 3 weeks of antibiotic therapy alone. The majority involved the lumbar region and often had instrumentation. With an average of 20 HBO2 sessions, all 19 spinal infections resolved. Of greatest clinical importance, no surgical debridement, revision surgery, or hardware removal was required to achieve infection resolution in any of the patients in this series.
That is a critical finding for spinal osteomyelitis. Avoiding spinal surgery and hardware removal is a major potential benefit. What's the conclusion recommendation for spinal osteomyelitis?
The ability of hyperbaric oxygen therapy combined with antibiotics to eliminate spinal osteomyelitis and potentially avoid hardware removal in a significant number of patients suggests that a trial of HBO2 should be considered prior to scheduling patients for extensive surgical debridement, especially where hardware removal is high risk or contraindicated.
Try HBO2 plus antibiotics first. Hope to save them the surgery.
Right. Thus, the addition of hyperbaric oxygen therapy to antibiotics, and if clearly indicated, limited surgical debridement, should be considered an American Heart Association Class 2A recommendation in patients with spinal osteomyelitis.
So the significant potential to achieve cure without major surgery or hardware removal seems to be a key factor driving that Class 2A recommendation for the spine.
Absolutely. It offers a less morbid pathway with promising results in a challenging site.
Let's micro-recap the evidence findings and recommendations for mandibular and spinal osteomyelitis.
Okay. For mandibular osteomyelitis, HBO2 alone is Class 3. Combined with antibiotics, it's Class 2B in adults, but Class 2A in children where avoiding disfiguring surgery is a priority. The trimodal approach of antibiotics, surgery, and HBO2 is Class 2A in refractory adults, maximizing clearance potential despite the challenges of these cases.
Mandible, 3 alone. IAW ABX adults, IAA kids pre-op, IAW Triad adults.
For spinal osteomyelitis, standard therapy can have significant failure rates. Studies using HBO2 with antibiotics, often without hardware removal, have shown high resolution rates, up to 100% in some series. This potential to avoid extensive surgery and hardware removal, especially where surgery is high risk, makes adding HBO2 to antibiotics and limited debridement an AHA Class 2A recommendation.
Spine, Class 2A with antibiotics plus limited surgery, driven by potential to avoid major surgery hardware removal. Moving on, let's examine the evidence for cranial osteomyelitis, infection in the skull itself.
The context for cranial osteomyelitis often involves surgery, particularly craniotomy, where the bone flap created is devascularized, increasing its susceptibility to infection, rates reported between 5% and 9% post-op. This also applies to implanted cranial prosthetics.
So a common post-surgical problem.
Right. Standard treatment to cure these infections requires antibiotics, surgical debridement, and frequently removal of the infected bone flaps or prostheses, another major surgery.
What do studies looking at HBO2 for this site show? Can it help avoid that revision surgery?
Wagner et al. Examined adjunctive hyperbaric oxygen therapy in 10 patients with refractory skull base osteomyelitis. Combining antibiotics and surgical debridement with HBO2, they achieved infection clearance in 80% of these previously refractory patients. The source notes that the 2 patients who didn't clear their infection had very limited HBO2 exposure before succumbing, suggesting that among those who completed therapy, the effective clearance rate was 100%.
That's a significant outcome in those who completed the protocol. 100% effective clearance.
Of potentially greater significance, Larson reported on patients who had failed antibiotic therapy for cranial osteomyelitis, none of whom had undergone surgical debridement prior to starting HBO2.
So HBO2 plus antibiotics before surgery.
Yes. In patients with uncomplicated bone flap infections and no risk factors, 80% resolved without the need for surgery. Even in patients with risk factors, prior surgery, radiation, etc., 62% resolved non-surgically.
Wow, 60–80% avoided surgery altogether.
And when adding in cures achieved after removing only small pieces of dead bone, sequestra, 94% of the complicated group resolved their infections. Overall success defined as clearance or avoidance of surgery was 97%.
Achieving high success rates and often avoiding the need for repeat craniotomy and bone flap removal is a major potential benefit. Does Larson's study look at the cost implications of this? Did saving the surgery save money?
Yes, the study provided cost data. They estimated that achieving primary cures using HBO2 therapy resulted in significant savings, specifically 48% to 66% savings compared to the cost of repeat craniotomy. Citing surgical costs versus HBO2 costs, they calculated a 2 to 3-fold savings over standard surgical treatment. The source notes these figures were in Swedish kroner, but the relative savings are substantial.
That's powerful data. Better outcomes, reduced surgery, and cost savings. What's the conclusion and recommendation for cranial osteomyelitis?
The evidence suggests that combining hyperbaric oxygen therapy with antibiotics and, where indicated, limited surgical debridement is very effective in eradicating refractory cranial osteomyelitis. Given the potential for non-surgical cure rates approaching 70% to 100% and the ability to minimize the risks and costs associated with repeat cranial surgery, a trial of HBO2 prior to undertaking major cranial debridement is warranted.
Makes sense to try it first.
Accordingly, in the setting of antibiotic refractory cranial osteomyelitis, hyperbaric oxygen therapy is recommended as an American Heart Association Class 2A therapeutic adjunct to standard care.
So, the potential to avoid risky and expensive repeat cranial surgery, coupled with promising success rates, earns that Class 2A recommendation. Let's move on to malignant external otitis, MEO. That sounds particularly nasty.
It is. Malignant external otitis is an aggressive form of osteomyelitis starting in the ear canal that tends to spread into the skull base and can be lethal. Historically, early reports showed mortality rates over 30% with antibiotics alone. While advances in antibiotics have improved survival to 80–90%, the source notes that these studies often didn't clearly distinguish the severity of bone involvement or the need for surgery, suggesting success was likely higher in less severe cases.
Well, survival improved, but maybe not for the worst cases. And disease severity in MEO is categorized by the Tisch classification. How does that relate to outcomes?
Yes. The Tisch classification system stratifies MEO severity based on local invasion and cranial nerve involvement from stage 1 to stage 4. Using the system, mortality rates with standard treatment, antibiotics plus surgery, increased dramatically with stage. 14% for stage IRA, 50% for stage 3, and a striking 70% for stage 4 disease.
Wow, 70% mortality for stage 4 with standard care. That highlights the need for better therapies in severe cases. How do these mortality rates compare when HBO2 is added?
Martel achieved resolution in 95% of 22 non-surgical cases using HBO2 plus antibiotics, though these weren't specifically identified as refractory. Nerozny focused on antibiotic refractory cases, showing 87.5% resolution with HBO2 with only one patient needing surgery. Davis treated 16 cases, including 6 advanced and refractory ones, with 30 days of HBO2 plus antibiotics, achieving resolution in all cases that persisted for years.
Resolution in all cases, even advanced refractory ones. That's impressive.
Skelly et al. Used HBO2 as a rescue in 23 patients refractory to prior antibiotics and surgery, achieving 78% resolution in this highly complex group. Tisch himself reported curing 95% of 21 antibiotic refractory MEO patients after adding HBO2. This is notable given that over half of his patients were severe stage 3 or 4V cases with historically high mortality.
Curing 95% of refractory stage 3 MEO is remarkable compared to the historical 50–70% mortality.
It really is. A comprehensive 2020 review by Bion et al. On 58 patients treated with adjuvant HBO2 for MEO, reported an overall cure rate of 91.4% and 8.6% mortality. Importantly, for patients with facial nerve involvement, CNC, they saw 72% return of function and a 93.8% survival, highlighting impressive outcomes even in the presence of cranial nerve deficits.
Those are impressive outcomes, especially for nerve function recovery and survival in a population with severe disease. What's the conclusion and recommendation for MEO? Is it stage dependent?
Yes. While less severe malignant external otitis often responds well to antibiotics and minimal surgery, HBO2 appears particularly effective in cases refractory to standard therapy, especially the higher stage 3 and 4 disease where extensive debridement and historically high mortality are major concerns. Adding HBO2 offers the potential to avoid highly morbid surgery and improve survival.
So it shines in the toughest cases.
Right. Thus, for stage 1 and 2 MEO, HBO2 is considered American Heart Association Class 2B therapy. However, for refractory cases, as well as those with higher stage malignant external otitis, stage 3, HBO2 is recommended as an American Heart Association Class 2A intervention.
So the recommendation for MEO is stage-dependent, stepping up to Class 2A for the more severe and refractory cases where the potential benefits in avoiding extensive surgery and reducing mortality are most pronounced.
Precisely. It reflects where the need and the evidence of benefit are greatest.
Let's micro-recap the evidence findings and recommendations for cranial osteomyelitis and malignant external otitis.
Okay. For cranial osteomyelitis, standard treatment often involves risky repeat surgery. Evidence suggests that HBO2 combined with antibiotics and limited debridement is very effective, with potential for high non-surgical cure rates and significant cost savings by avoiding repeat craniotomy. This earns it an AHA Class 2A recommendation in antibiotic refractory cases.
Cranial, Class 2A, avoid surgery, saves money.
For malignant external otitis, a potentially lethal condition with mortality increasing significantly with stage, HBO2 is particularly effective in refractory stage 3 cases, showing high cure rates and improved cranial nerve outcome survival. The recommendation is stage-dependent. Class 2B for stage 3 and Class 2A for refractory or higher stage disease.
MEO, Class 2B, stage 3, Class 2A, refractory stage 3, driven by severity and outcomes. We have two more site-specific areas to cover: sternal osteomyelitis and diabetic foot osteomyelitis, before we discuss safety and utilization review. Let's tackle sternal first.
For sternal osteomyelitis, the incidence after coronary artery bypass grafting is around 2.1%. High rates of surgery are needed, 89%, and even then 30% fail initial surgery. How does adjunctive HbA2 compare? Does it improve these numbers? Adjunctive hyperbaric oxygen therapy appears to improve outcomes compared to these historical failures. In a small series of lung transplant patients, 4 with sternal osteomyelitis were treated adjunctively with HBO2. Despite being immunocompromised, 2 of 4 healed completely without surgery. 1 more healed with skin grafting. The 4th refused HBO2 and died.
So 3 out of 3 who got the therapy cleared infection, 2 without any surgery. That's very encouraging data, especially in a vulnerable population. We discussed the U study earlier, but its findings are very relevant here for sternal infections. Remind us.
Indeed. As we mentioned, Udall's retrospective analysis of 12 patients with sternal osteomyelitis showed that adding HBO2 to antibiotics and debridement led to significant reductions in ICU stay, 8.7 versus 48.8 days, mechanical ventilation positive pressure support duration, 4 versus 34.8 days, and critically overall mortality, 0 versus 3 cases.
Shorter ICU, less vent time, 0 mortality versus 3 deaths.
These dramatic improvements in critical care needs and survival strongly imply significant clinical benefit and potential cost savings. Litwinovich et al. Also reported on 10 patients with deep sternal wound infections after cardiac surgery who failed conventional therapy. Adding 20 HBO2 sessions achieved complete wound closure in 80% with no complications.
80% closure in failed cases. And Borelli's prospective trial for sternal infections provides the strongest evidence here. What were those key findings again?
Yes, Borelli's trial, which the source calls the most rigorous, showed that adding HBO2 for sternal infections resulted in significantly lower infection relapse rates, 0% for ACE, 33.3%, shorter durations of intravenous antibiotics, 47.8 versus 67.6 days, and reduced total hospital stay lengths, 52.6 versus 73.6 days.
Shorter everything. Reduced relapse, reduced mortality, reduced critical care needs for a very difficult infection. What's the overall conclusion and recommendation for sternal osteomyelitis?
While the number of studies is limited, these series consistently demonstrate that hyperbaric oxygen therapy is effective in reducing the need for repeat sternal debridement and Axtor extensive surgical interventions and improves critical outcomes. Consequently, hyperbaric oxygen therapy should be considered an American Heart Association Class 2A adjunct in the management of sternal osteomyelitis.
That Class 2A recommendation aligns with the significant benefits seen in survival and reduced morbidity. Now let's discuss diabetic patients and associated osteomyelitis, particularly in the foot. This seems like a huge area.
Although covered extensively in another chapter of the publication, the source notes that a large proportion of patients presenting for refractory osteomyelitis treatment have comorbid diabetic foot ulcers. In fact, some experts contend that osteomyelitis can be presumed present in virtually all diabetic patients with plantar foot ulcers, especially if bone is exposed.
So diabetic foot ulcers are frequently complicated by underlying bone infection. They often go hand in hand.
Yes. And the body of literature evaluating management strategies for Wagner grade 3 and 4 diabetic ulcers provides some of the highest level of evidence supporting the use of hyperbaric oxygen therapy for associated refractory osteomyelitis.
Ah, so the diabetic foot ulcer literature provides strong evidence for the osteo within it.
Exactly. Citing pooled data from 5 randomized controlled trials involving 118 patients with diabetic ulcers, Ruckel-Wiedemann concluded that adjunctive hyperbaric oxygen treatment confers a significant reduction in the risk of major amputation. The risk ratio was 0.31, meaning the risk of major amputation was reduced by nearly 2/3 with HbO2. Imagine avoiding amputation for these patients.
A nearly 2/3 reduction in the risk of amputation. That is an incredibly powerful clinical benefit for this patient population. That's life-changing.
It is a profoundly impactful finding. Furthermore, other randomized prospective trials have also shown that hyperbaric oxygen therapy can improve the mean rate of healing in diabetic foot ulcers. Consequently, hyperbaric oxygen therapy is not just recommended, it is accepted as an American Heart Association Class 1 therapy for refractory osteomyelitis associated with Wagner grade 3 or 4 diabetic foot ulcers.
American Heart Association Class 1, that is the highest level of recommendation possible, indicating strong evidence and widespread acceptance for this specific indication. A definitive role for HbO2 here in saving limbs.
Correct. It's a critical tool in preventing amputation in this population based on randomized trial data.
Let's transition now to safety considerations. We've heard about benefits, but what are the known risks or side effects of hyperbaric oxygen therapy, and how frequently were they reported in the context of treating osteomyelitis? Is it safe?
While hyperbaric oxygen therapy is generally considered safe and well tolerated, it is associated with known potential adverse side effects. The source notes these are discussed in detail elsewhere, but specifically in the setting of refractory osteomyelitis treatment reviewed here, reports of significant adverse effects related to hyperbaric oxygen exposure have been rare.
Okay, rare in this group. What were the most common events reported in this specific patient population? What did people experience?
As is common with most clinical hyperbaric oxygen treatments, the most frequently reported events were middle ear and sinus barotrauma, essentially pressure-related discomfort or injury to the ears or sinuses during pressurization or depressurization, ear pain or popping.
Okay, the ear squeeze. Is it serious?
These pressure-related events were typically described as mild and self-limiting. While a few authors reported the need for minor interventions like placing tympanostomy tubes to help patients equalize pressure and continue therapy, crucially, no patient being treated for osteomyelitis in this literature review was reported to have discontinued hyperbaric oxygen therapy specifically because of barotraumas.
So, manageable discomfort. Maybe needing air tubes sometimes, but not treatment-stopping issues. What about the potential risks of breathing high concentrations of oxygen, like oxygen toxicity, seizures, lung problems?
In evaluating potential side effects associated with repeated exposure to elevated oxygen partial pressures, only transient myopia, temporary nearsightedness was reported in this review.
Temporary blurry vision.
Right. This characteristic temporary change in vision spontaneously resolved in all cases after the completion of the hyperbaric oxygen therapy course. More permanent visual changes, such as cataract formation, which is sometimes mentioned as a theoretical long-term risk with cumulative hyperbaric exposure, were not reported in this patient population treated for osteomyelitis.
No cataracts reported here. What about seizures or lung issues?
Similarly, the source states that no reports of central nervous system oxygen toxicity, like seizures or pulmonary oxygen toxicity, lung damage, could be found in the reviewed literature for this specific indication.
That's quite reassuring regarding the safety profile in this patient group. Pretty safe overall, then. What's the overall safety conclusion?
As the addition of hyperbaric oxygen therapy to osteomyelitis treatment regimens in the reviewed literature was not associated with reports of significant adverse side effects, adjunctive hyperbaric oxygen therapy should be considered a safe, well-tolerated intervention in the management of refractory osteomyelitis.
That provides important context for weighing the risks and benefits. Let's micro-recap the evidence and recommendations for sternal and diabetic osteomyelitis and the safety findings.
Okay. For sternal osteomyelitis, studies show HbO2 as an adjunct to antibiotics, and debridement is effective in reducing the need for extensive surgery, improving critical care outcomes, reduced ICU, ventilation, decreasing mortality, and reducing relapse rates. Class 2A recommendation.
Sternal. Class 2A improves outcomes, reduces surgery mortality.
For diabetic patients with Wagner grade 3 or 4-foot ulcers and associated refractory osteomyelitis, strong evidence from pooled randomized controlled trials shows a significant reduction in major amputation risks and improved healing, making it an American Heart Association Class 1 therapy the highest recommendation.
Diabetic foot osteo Wagner 34. Class 1 prevents amputation.
Regarding safety, adverse events are rare in this population, primarily mild barotrauma and transient myopia. No reports of significant oxygen toxicity or long-term visual changes were found, supporting HBO2 as a safe, well-tolerated adjunct.
Safety. Good profile, mostly minor ear issues and temporary vision changes. We've now completed the site-specific evidence review and covered safety. Let's bring it all together for the overall evidence-based conclusions and discuss how the therapy's continued use is reviewed. What's the big picture?
To summarize the overall evidence-based conclusions drawn from the source, it reiterates that the majority of available human data for chronic refractory osteomyelitis comes from retrospective clinical case series, primarily providing American Heart Association Level 5 evidence. While a few studies were Level 3 or 4 due to using control or comparative groups, the highest level of evidence, Level 1 or 2A from randomized controlled trials, is largely absent for this indication broadly.
Okay, evidence quality is generally low, mostly Level 5.
That said, the source emphasizes that the overwhelming majority of these available studies across different sites and methodologies supported the use of hyperbaric oxygen therapy as a beneficial adjunct in the management of refractory osteomyelitis.
But despite weak evidence design, most studies show a benefit.
Exactly. And where were the most successful outcomes seen consistently?
That was with the Triad, right?
Yes. The highest reported osteomyelitis cure rates were consistently obtained when hyperbaric oxygen therapy was combined with culture-directed antibiotics and concurrent surgical debridement, the Triad approach.
The Triad yields the best results.
What does this accumulated evidence, despite its limitations, lead to in terms of a general recommendation?
It seemed to land around Class 2 overall.
Correct. As the treatment success rates achieved with adjunctive HBO2, particularly when used in the Triad, generally exceeded the reported success rates for standard of care, antibiotics plus surgery alone. In this refractory patient population, hyperbaric oxygen therapy can be generally recommended as an American Heart Association Class 2 adjunct in refractory osteomyelitis.
Generally Class 2. Are there specific clinical settings that earned a higher level of recommendation based on the evidence? Where does it get stronger support?
Yes, certain clinical settings were identified as warranting a higher recommendation. Specifically, osteomyelitis involving children or bone structures adjacent to the central nervous system or other vital organs are special indications where there's a favorable risk-benefit balance. Here, a trial of HBO2 and antibiotic therapy prior to attempting extensive high-risk surgical debridement is supported and earned an American Heart Association Class 2A recommendation.
Class 2A for kids and critical sites trying to avoid big surgery.
Right. This is due to the potential to achieve cure with a less morbid approach in these critical areas.
And what about the highest recommendation? Where was it Class 1?
As we discussed, for patients with refractory diabetic ulcers classified as Wagner grade 3 or 4, adjunctive hyperbaric oxygen therapy is definitively regarded as an American Heart Association Class 1 intervention. This is based on the strong evidence for amputation prevention in this specific population.
Class 1 again for severe diabetic foot osteo. What about using HBO2 without adequate surgery? What class was that?
In contrast, the combination of hyperbaric oxygen therapy and antibiotics alone, without adequate surgical debridement, and most other forms of uncomplicated primary extremity or miscellaneous site osteomyelitis, typically garners only American Heart Association Class 2B support.
Only Class 2B without the surgery.
This reflects that while there may be some benefit, it's less well established and generally not superior to optimizing the surgical component. The source notes that this variability in recommendations across sites and approaches is expected, mirroring the variability in treatment success seen with standard care alone for different types and locations of osteomyelitis.
And finally, the safety aspect, just to confirm.
The source reiterates the safety findings. While one prospective study, Bester High, reported no benefit, no study reported significant negative treatment effects from adding HBO2. Since it was not associated with reports of significant adverse side effects in this patient population, adjunctive hyperbaric oxygen therapy should be considered a safe, well-tolerated intervention.
Okay, safe and generally beneficial as an adjunct, especially with surgery. Let's move on to utilization review. Given the variability in the total number of treatments needed, how should clinicians decide when enough is enough, or when to modify the plan? How long should you keep treating?
As previously discussed and based on the review, no single specific recommendation can be made for the total number of hyperbaric oxygen treatments required for all cases. Duration must be judged based on each patient's individual clinical response.
Based on response, not a fixed number.
Right. If a patient shows a positive response to the initial management plan, appropriate antibiotics, indicated surgical debridement, and concurrent hyperbaric oxygen, then continuing the antibiotics and HbO2 for approximately 4 to 6 weeks is considered a Class 2 intervention, aligning with the typical revascularization period.
So 4-6 weeks is reasonable if it's working.
At what point should utilization review typically occur? Board-style question. At what point should utilization review for HbO2 therapy typically be considered for refractory osteomyelitis?
That sounds like around the end of that initial period.
Exactly. Although clinical circumstances can vary, suggesting continuation might be needed beyond the initial 4 to 6 weeks, the source states that utilization review is generally indicated after completion of 30 to 40 hyperbaric oxygen treatment sessions. This serves as a practical checkpoint.
30 to 40 sessions, time to formally reassess. What if the patient isn't showing prompt improvement or progress seems to stall by that 40 session mark? What if it's not working?
In that scenario, if there is no prompt clinical improvement or progressive healing stalls, the existing antibiotic and hyperbaric oxygen regimen is explicitly stated as being unlikely to be clinically effective. The source is clear. Continuing that same regimen without modification should be considered an American Heart Association Class 3 intervention. It's not recommended.
Class 3. So just pushing forward with a failing regimen is actually contraindicated. What should be done instead?
Instead, clinical management strategies must be reassessed. This requires a careful review and implementation of additional surgical debridement and indoor adjustment of antibiotic therapy without delay.
Back to basics. Fix the surgery, fix the antibiotics immediately.
Right. Subsequent to these necessary treatment modifications, after the surgeon has reevaluated and potentially redebrided, or the antibiotic regimen has been optimized based on new information, the accumulated clinical evidence suggests that reinstitution of adjunctive hyperbaric oxygen therapy will still help maximize the overall chances of achieving resolution of the refractory bone infection.
So the flowchart logic holds true here. If it's not working after a reasonable trial, 30-40 sessions, stop and reassess the surgical and antibiotic foundation, then potentially bring HbO2 back in to support the revised plan.
Exactly. Regardless of the specific clinical presentation or how far into therapy the patient is, the general rule for utilization review is recommended after a total of 30 to 40 treatments to ensure efficacy and guide further management.
Let's micro-recap the overall evidence conclusions and the guidance on utilization review.
Okay. The overall evidence, predominantly from lower-level human studies but supported by animal data, suggests HbO2 is a beneficial and safe adjunct in refractory osteomyelitis, generally receiving an AHA Class 2 recommendation.
Generally Class 2 beneficial adjunct.
The recommendation is elevated to Class 2A for critical sites, cranial, spinal, sternal, pediatric, often allowing a trial before extensive surgery, and for stage 3B/4B when combined with concurrent surgery antibiotics. It's a strong Class 1 for refractory diabetic foot osteomyelitis, Wagner 34.
Class 2A critical site skid stage 3B/4BW Triad, Class 1 diabetic foot.
HbO2 plus antibiotics without adequate surgery is typically Class 2B, and continuing an ineffective regimen or using HbO2 alone is Class 3.
Class 2B without surgery, Class 3 if ineffective or alone.
Utilization review is generally recommended after 30-40 sessions. If response is poor, reassess and modify surgery antibiotics without delay, then potentially reinstitute HbO2 rather than continuing the ineffective regimen.
Review at 30-40 sessions, modify if failing, don't continue ineffective therapy. Finally, let's address the often asked question about cost impact. Hyperbaric oxygen therapy sessions have a cost associated with them. Does adding HbO2 to the complex management of refractory osteomyelitis increase or decrease overall healthcare costs? What's the financial story?
This point might seem counterintuitive because individual hyperbaric oxygen sessions are not inexpensive. However, the source argues that when used appropriately, within the established guidelines for refractory osteomyelitis, adjunctive hyperbaric oxygen therapy can decrease overall healthcare costs.
How does that work? How can adding a costly therapy potentially reduce overall costs? It seems paradoxical.
The argument is that you are preventing or reducing the need for more expensive downstream interventions. Strauss's analysis on a series of complicated osteomyelitis cases reported an average expenditure of $204,000 on hospitalization and treatment before hyperbaric oxygen therapy was started. This is the cost of trying and failing with standard therapy alone.
Wow, over $200,000 already spent before HBO2.
Yeah. Once HBO2 was initiated and combined with surgery and antibiotic therapy, the additional expenditure for the HBO2 component and related care was approximately $35,500 per patient. In the source notes, these are normalized dollar values.
So they'd already spent $204,000, and adding HBO2 to a renewed effort cost another $35,500.
Yeah.
That still sounds like more money.
Yes. While that $35,500 represented a 17% increase in cost at that point in the patient's long treatment journey, the crucial projection was that these patients, having already failed extensive prior standard care, would have incurred equal or greater costs if they had simply continued with the failing standard interventions.
So it prevents even more spending down the road.
Exactly. By adding HBO2, they achieved resolution or better outcomes that prevented potentially endless cycles of additional surgeries, hospitalizations, and prolonged, expensive IV antibiotic courses. Consequently, Strauss's work calculated the cost-effectiveness as being fivefold in favor of adjunctive hyperbaric oxygen therapy in refractory osteomyelitis. You get significantly more clinical benefit, leading to less future expenditure for the investment in HBO2. Imagine 5 times the bang for your buck.
5 times the cost effectiveness that's a significant financial benefit projected. That flips the script.
This finding aligns with Larson's study on infected cranial bone flaps, which demonstrated that HBO2 could resolve the infection and prevent the need for revision cranioplasty, a costly surgical procedure. Larson cited surgical costs significantly higher than the cost of HBO2 therapy, resulting in a calculated 2 to 3-fold savings by using HBO2.
2 to 3 times savings in the cranial cases by avoiding surgery.
We also saw data suggesting reduced hospital stays, particularly in sternal infections. Does that translate to cost savings?
It must, right. Less time in the hospital equals less money spent.
Yes, directly. Riddick et al.'s analysis of patients treated with HBO2 for sternal wound infections found a relative reduction in hospital lengths of stay and pharmacy costs, calculating savings of over $11,000 per case, or about 12%. Furthermore, a Canadian technology assessment by Sheps noted that while the overall management costs for chronic osteomyelitis are very high, potentially $144,000 to $360,000 per case, the cost associated with hyperbaric oxygen therapy itself accounts for only about 5% of that total cost.
Only 5%. So the cost of the HBO2 sessions is relatively minor compared to the overall cost of failing to resolve the infection and needing repeat surgeries, long hospital stays, etc.
Exactly. This frames the cost of HBO2 as a relatively small part of the overall financial burden of managing chronic, complex osteomyelitis, where the majority of the cost is tied up in long hospital stays, surgeries, and extensive antibiotic use.
So the focus should be on the big cost drivers, which HBO2 might help reduce.
Precisely. And the clinical benefits we discussed earlier also provide insight into these implied cost savings, even without specific dollar figures. Yu et al.'s sternal osteomyelitis study showing significantly decreased ICU stay, reduced duration of ventilation, and reduced mortality directly translates to huge cost reductions by avoiding incredibly expensive critical care resources.
Avoiding the ICU saves a fortune.
Similarly, Bareilles study showing shorter durations of IV antibiotics and shorter hospital stays directly equates to lower pharmacy costs and reduced daily hospital costs.
That's a powerful point. The financial investment in HBO2 is potentially offset, sometimes significantly, by preventing more expensive complications and reducing the need for other costly resources required to manage uncontrolled or recurring infection.
That's the overall summary on cost impact. While HBO2 therapy has a standalone cost, its addition to the management of appropriately selected patients with refractory osteomyelitis appears associated with a reduction in the total need for repeat surgical procedures, shorter courses of antibiotic therapy, especially shorter durations of intensive care and overall inpatient management, and consequently a reduction in overall healthcare expenditures.
So the data suggests it's an investment that can potentially lead to better clinical outcomes and be more cost-effective in the long run for these complex cases. Let's micro-recap the cost impact.
Okay. Cost analyses suggest that while HbO2 therapy has an upfront cost, its adjunctive use in refractory osteomyelitis can lead to overall healthcare cost reduction. Strauss's analysis showed a five-fold cost effectiveness by preventing continued failing standard care.
Five-fold cost-effective.
Larson demonstrated 2 to 3-fold savings by avoiding revision surgery in cranial cases. Riddick reported about 12% savings from reduced hospital stay and pharmacy costs in sternal infections. Sheps noted HbO2 as a small percentage, maybe 5%, of the total high cost of managing chronic osteomyelitis.
A small part of the total bill, big potential savings elsewhere.
Studies showing reduced ICU stays, ventilation mortality, antibiotic duration, and hospital stays, like U and Barilli, directly translate to substantial implied cost savings. The overall message is that HbO2, despite its cost, appears associated with reduced overall healthcare expenditures in appropriately selected refractory patients by improving outcomes and preventing more costly downstream events.
Wow. We have dissected this source material sentence by sentence, fact by fact, to understand refractory osteomyelitis and the role of hyperbaric oxygen therapy. We've covered the definition, the biological mechanisms, how patients are selected and classified, the challenges at specific anatomic sites, the clinical management details, the evidence supporting its use, and resulting AHA recommendations, safety, utilization, and cost. It's been a true deep dive.
We've built a detailed picture based on the accumulated literature presented in the source, highlighting the complexities and the nuanced role of this therapy. It's definitely not simple.
Absolutely. And now for our end-of-chapter mega recap, pulling all these threads together. We started with a challenge, refractory osteomyelitis, this stubborn bone infection that just doesn't respond to standard antibiotics and surgery alone. A real clinical headache.
Definitely. Then we looked at the why behind considering hyperbaric oxygen, the mechanistic rationale. It works by jacking up oxygen levels in that hypoxic bone.
Right, getting oxygen to the tissues.
Which then enhances our own immune defenses, like leukocyte killing and osteoclast function for cleanup, makes certain antibiotics work better by boosting their transport, helps promote new blood vessel growth, angiogenesis, for healing, and reduces inflammation, basically creating a better environment for healing and fighting infection.
So multiple biological benefits from that extra oxygen. Then patient selection using systems like Synergistic and Wagner to help identify candidates, especially those stage 3 or 4 infections, the compromised B hosts, or the high-risk Wagner 34 diabetic ulcers. But ultimately, it's the clinical reality of the infection being refractory or progressive that drives the decision.
Classification helps, but failure of standard care is the key. We then looked at the special indications, the sternum, spine, cranium, malignant external otitis, where standard therapy often falls short, the risks are sky high, and the need for effective adjuncts is critical.
Those high-stakes locations, which led into clinical management, tailoring the therapy, crucially timing HbO2 with appropriate surgery, the typical parameters like 2.4, 2.5 ATA pressure, daily sessions for 90, 120 minutes.
And that initial 4 to 6 week course or 20-40 sessions, but also the vital importance of reassessing. If there's no response, don't just keep going. Modify the surgery or antibiotics first, then consider restarting HbO2.
Fix the foundation first. Then the evidence, acknowledging the limitations, mostly level 5 human data, lots of case series.
But seeing consistency across those studies, plus strong animal data supporting that synergistic triad of antibiotics, surgery, and HbO2.
Which culminated in the American Heart Association class recommendations. That's strong Class 1 for Wagner grade 34, diabetic foot osteomyelitis, saving limbs.
The highest level.
Then Class 2A for those critical sites, cranial, spinal, sternal, pediatric, often allowing a trial before big surgery, and for the more severe Synergistic stage 3D, 4B when combined with concurrent surgery antibiotics, and for those facing potential amputation.
Class 2A covering those high-risk or salvage situations.
Class 2B typically for HbO2 plus antibiotics alone and less complicated sites without sufficient surgery, showing it's less effective without the debridement. And Class 3 for HbO2 monotherapy, or, importantly, for continuing ineffective regimens.
Don't use it alone. Don't keep using it if it's not working without modification.
We confirmed the safety profile generally well tolerated in this population, mainly minor ear issues or temporary vision changes, and discussed utilization review, typically around 30-40 sessions as a checkpoint, guided by clinical response.
And finally, we connected cost to clinical outcome, reviewing the data suggesting that despite the costs of the sessions themselves, HbO2 appears to reduce overall management costs by preventing more surgeries, shortening hospital and ICU stays, cutting antibiotic courses, and ultimately leading to better resolution. 5-fold cost effectiveness in one study.
So the central message seems to be, While hyperbaric oxygen therapy isn't a standalone miracle cure for refractory osteomyelitis, and it often lacks that gold standard level 1 randomized trial data across the board.
The weight of the accumulated evidence, from animal models to numerous human series and a few controlled trials, supports its use as a valuable, safe, and potentially cost-effective adjunct.
An adjunct's part of a team.
Exactly. It's a tool in the comprehensive management of appropriately selected patients, working best when integrated into that multimodal triad involving culture-directed antibiotics and definitive surgical debridement. Board-style question. Considering the evidence presented, what is the overall AHA class recommendation for adjunctive HBO2 in refractory osteomyelitis, and what factors can elevate or lower this recommendation?
Overall, it seems to sit at Class 2, but it gets elevated to 2A or even Class 1 when used with a full triad in severe refractory cases, especially in critical sites or diabetic feet, and potentially downgraded to 2B or even 3 if used without adequate surgery or if therapy continues despite lack of response.
Precisely. It's nuanced based on the clinical context and how it's applied.
And as we wrap up this deep dive, it leaves us with a thought to consider, building on the evidence we've reviewed today. For those challenging cases at critical anatomic sites, the spine, the skull, the sternum, where standard surgical options are often severely limited or associated with potentially catastrophic risks, does the accumulated evidence, despite its limitations and the highest level of study design, present a compelling ethical imperative to consider therapies like hyperbaric oxygen that offer a reasonable prospect of cure, potentially with less morbidity and even cost savings, even if those therapies currently rest on a foundation of Class 2A or 2B evidence, rather than the Class 1 evidence we might prefer for less complex scenarios?
That question really gets to the heart of clinical decision-making in the face of complex, high-stakes problems where perfect evidence is unavailable, but patients urgently need effective options. Risk versus benefit when the standard options are poor.
Indeed. And that brings this deep dive to refractory osteomyelitis and hyperbaric oxygen therapy to a close. Thank you for joining us.
Thank you. It was a harrow discussion.
Until next time.